you hear me?
Yes, ma, you're welcome. I can hear you, ma.
Okay, can you hear me clearly? Okay,
Very
because I
clear,
don't
ma.
want to use my microphone. Okay, Professor Kushimo has problems sharing her slides from an Apple computer,
Okay.
from an Apple laptop. So she sent the slides to me.
Okay,
So
ma.
you need to project them.
Okay,
So
ma.
I'm going to send them to Moni now or Aaron because I don't have your email.
Okay, ma. All right.
Huh?
Okay,
So
ma.
when is her lecture? She's on. Professor Kushima is on. I see she's on already.
Yes,
So you
yes.
will share it for her.
Okay, ma. Okay.
Okay. All right.
All
So
right.
let me just do that. Then let me just make sure my video is okay and I'm looking fine.
Yes, ma, you're welcome.
Okay, that's fine. That's good. Okay, thank you. So let me just get her lectures out. Okay, Professor Kushima has problems.
Good morning. Professor Kushima stepped away for a moment, but we're going to test her video on this end as well.
Okay, great. Thank you. I don't know if you can, if I'm still on.
You're
I'm
still
sorry?
home. You're home, ma.
Yes, you're
Okay,
still
great.
on.
Thank you. Thank you. Moni and Aaron, should I send it by email? The lecture, Professor Kushima's lecture.
You can send if it's okay, ma.
Is it email I should send it or WhatsApp? That's what I'm asking you.
Whichever one is convenient for you, or you can send both, ma.
All right. Okay, I'll do that now.
Good evening, all. Our IT, please, can you send reminder emails to all participants that are starting now? Thank you.
Hello, good morning. I think I was able to figure out the screen sharing. I'm just going to test it one moment, if that's okay.
Yes, please.
Can everybody see this?
Yes. Oh, that's
Yes.
brilliant.
Okay,
Great.
perfect. Thank you.
So we don't need to share from this end.
Yes, I think we're fine. Thank you.
Okay, great. Thank you.
Thank you.
Prof. Desaluman, you are here to send Professor Kushimo's lecture.
I've sent it.
Oh, okay, I haven't
You
seen
haven't
it.
received it?
No, ma. I've been checking my mail and WhatsApp.
No, WhatsApp. I sent it by WhatsApp. Aaron, have you received it, please? Sorry?
I've received it.
Okay. So Aaron has received it. I sent it exactly the same time. I don't know why yours hasn't come through. I'm looking at the WhatsApp, it's gone. Anyway, Monish, you can now share it, so that's fine. And then we have a backup with Aaron. But let me see if I can send it to you as well.
Okay, ma. Thank you.
Let me see what I can do.
Good evening. Please, I just want to make sure my mic is working. Dr. Aaron, can you hear me, please? Thank you.
Your mic is working.
Thanks. IT man, I just told you to please send a reminder email. I don't know if you heard me when I said it.
I heard you, ma. I'm actually on it at the moment.
Thank you.
Yes, you're welcome.
Hey, everybody.
Hi, Rebecca. Good to see you.
Hi, Rebecca.
Hey, Monkey.
Hi,
So
how are
nice to
you?
see you.
Nice
Oh,
to
I'm
see you.
Yeah.
Thanks.
Yeah.
I don't know what time it is at your end, but thank you so much. Hi,
And
Mary.
no,
Lynn.
it's only 5 o'clock here, but we've got no power. We've got load shedding. So thank goodness the sun's still out, and I've got Wi-Fi on a
You got a
power
backup for the
thing, just for the computer, just for the Wi-Fi.
okay. That's
And I
great.
made
You
sure
have a
everything was
backup for the
charged.
backup.
Yeah,
That's
exactly.
great. Thanks. Thanks for being here.
Yeah, no worries. I'm going to turn off my my camera now. I was just testing it. Okay, good luck for today.
Yes, ma'am.
That's a preliminary talking.
So good evening, ladies and gentlemen. Today is the 9th day in the month of September 2023, and it's glad to have us here. You are all welcome to this special webinar commemorating the first anniversary of the Pediatric Anaesthesia Society of Nigeria, PASoN. And we look forward to a great and impactful meeting. I want to especially welcome our guest speakers for making it early to the platform. I also want to appreciate everyone, surgeons, anesthetists, and other people we've invited who will be joining us for this program. The outline for tonight is as displayed on my screen. And in a very short moment, I'll be inviting the president, Professor Ibirunke Desalu, to give a welcome address. So let's take note. We are having 5 lectures, and there'll be question and answer after each session. We are encouraged to make the good use of the question and answer button to drop our questions so that we can attend to them at the appropriate time. Without wasting any time, please join me in as I welcome Professor Desalu, President, Pediatric Anesthesia Society of Nigeria, PASoN, for our welcome address. The theme of tonight's meeting is making pediatric anesthesia safer. And I know we are here because of our passion for safety and our special interest in this special group of patients, the pediatrics. So, Prof, you are welcome.
Thank you very much, Dr. Aaron. I think you need to stop share. Okay, here we are. It gives me great pleasure to welcome you on behalf of the Board of Trustees, executives, and members of Paediatric Anesthesia Society of Nigeria, PASoN, to our maiden scientific conference to mark our first year anniversary. PASoN was born on the 7th of September, 2022. We started with 27 members and have steadily grown to 67 members as of last month. Our members and trustees are specialists across the country and diaspora. The present situation in Nigeria regarding anesthesia workforce is dismal, with a physician anesthetist population ratio of 0.58 per 100,000 population. The 2022 population of Nigeria is 210 million, with an estimated 43% of our population being children under the age of 15 years. This means that Nigeria has a pediatric population of over 90 million. Research showed that our children are subjected to an unequal standard of anesthesia care depending on their location, and a large number are cared for by non-physician anesthetists and other cadres of health workers. This is likely to cause the high morbidity and mortality we see, especially in neonates. PASoN was created to address this problem by bringing together consultant physician anesthetists with interest in pediatric anesthesia to develop a network of professionals who would interact and formulate attainable solutions to ensuring safe anesthesia for our children. Our vision is to promote and set standards for the safe provision of anesthesia and sedation in children in accordance with global best practices. We aim to achieve this by improving skills and competencies of members, as well as advancing the subspecialty of pediatric anesthesia through training, research, education, and leadership. Since inception, we have made giant strides in education and training. We delivered safe PEDS training courses in Lagos and Abuja, and courses are scheduled for Port Harcourt and Kano later this year. This could not have been achieved without the financial support of Smile Train and assistance from the World Federation of Societies of Anesthesiologists, WFSA. We have fostered unity between members in different institutions and encouraged exchange of professional ideas and competencies. I really believe that we can help train ourselves. We understand the importance of collaboration with other professional bodies and organizations involved in the care of children. And PASoN was involved in the NSOP meeting held in Abuja last year. We look forward to more local, regional, and international collaborations. At this point, I would like to express my deepest appreciation to the Nigeria Society of Anesthetists, NSA, for supporting us in every way, all the way. This conference comprises of talks on various aspects of pediatric anesthesia, which will make our practice safer, from airway management and regional techniques to critical incident reporting, research ethics in children, and the successes and challenges of delivering pediatric anesthesia in Nigeria. All our speakers are seasoned professionals with experience in their field. I appreciate the executive committee who worked relentlessly to organize this mini conference, as well as our surgical and other colleagues who are here to support us. I thank all our speakers for taking out of their time to talk with us, despite the different time zones. And I urge you all to stay and enjoy our excellent speakers over a variety of topics. Thank you very much for joining us.
Thank you very much. I want to especially appreciate once again the President for the welcome address. Without wasting our time, we want to go straight to the next item on our program, and that will be the first lecture for the day, with the topic, Regional Anesthesia in the Neonate, What Options? And to do justice to this evening, we have in our midst Dr. Raymond Ndikonta. Please permit me if I have not pronounced that name correctly. Raymond is a pediatric anesthetist with a passion for safe neonatal anesthesia and improving outcomes in resource-constrained settings. He's a senior lecturer at the Faculty of Medicine and Biomedical Sciences and a senior consultant at the Yaoundé Gynaeco-Obstetric and Pediatric Hospital. He has been very active in building the subspecialty, not only in his native country, Cameroon, but elsewhere on the continent where the need arises. He is also a core faculty member of the Pediatric Anesthesia Training in Africa, PATA, through which he has made a contribution to education through simulations, training, research, and best practice promotion in pediatric anesthetic care. He's a strong penchant for neonatal perioperative care, regional anesthesia, and the use of ultrasound as a standard of care. We are glad to have you in our midst tonight as you deliver your lecture, Regional Anesthesia in the Neonate, What Option? Dr. Raymond, you are welcome.
Thank you very much for that introduction. I'm going to go straight ahead to share my screen and begin this little talk I have prepared on the regional anesthetic options in neonates. As you rightly said, Mr. Moderator, it's a passion I have, and it's always a pleasure for me to talk about neonates and how important they are, how fragile and how necessary we need to focus on their care. So I'm going to quickly share my screen. All right. Just give me a few seconds. Okay. Okay. It's just bear with me at the beginning. Okay. So the topic which we'll look at today is regional anesthesia in the neonate. What options do we have? So we'll begin by simple facts. What are neonates like? The first thing is we all know neonates are cute. They're these little beings at the beginning of their lives, fragile, immature, They're small compared to adults, and they're just different from the anatomy, physiology. And as such, they should be managed differently. Looking at pain management, which is actually one of the main aspects that we look at when we talk about anesthesia, many studies have shown that pain management strategies are really grossly underutilized. Pain assessment and needle pain prevention and treatment should be prioritized in pediatric acute care and neonatal care settings. We know this because in the neonates, these are people who don't speak up, they're fragile, and sometimes care is given to them without really considering the fact that these beings, although they can't talk or communicate, they feel pain. And as such, is an important aspect we should look at when managing these children. Some studies have shown that regional anesthetic techniques are very important in ensuring proper pain management in all patients, especially considering neonatal patients who have this barrier of communication with us. They don't talk, they're just there lying there, cute and as fragile as they can be. So, sorry, next slide. So what is specific? What do we need to consider when we think about the options, the regional anesthetic options in children? First of all, from a physiological point of view, we should remember that children have these three aspects which are going to influence how our anesthetic drugs are going to act on them. The first thing is they have a greater volume of distribution. Due to the fact that they have immature systems, they have lower drug clearance, and they have a higher free non-protein bound fractions, which brings out 2 points. Important to note. The large volume of distribution counteracts the potential for toxicity, meaning that although they are immature, the fact that the drug spreads out to a larger volume somehow reduces its potential for toxicity. And as such, same or higher doses per weight for single shot anesthetic techniques are possible. This is important, and you will see that when we'll talk about the different options that are available. But this is just to set the background on how different neonates are from adults. Another thing we should consider is in terms of the metabolism. Now, neonates have this issue of immaturity, especially in the liver and the enzymes that are responsible for metabolism. Specifically, when we talk about local anesthesia, we talk about local anesthetics, local anesthetic drugs. Cytochrome P1A2, which is very important for the metabolism of ropivacaine, only gets mature from 4 to 7 years old, meaning that in the neonate, we have to be very careful about how we use these medications. Also, cytochrome P3A4, which is responsible for the metabolism of levobupivacaine, matures only from the age of 12 months. However, we have drugs like 2-chloroprocaine, which have a liver-independent metabolism and as such are ideal for prolonged local anesthetic infusions. Unfortunately, this drug is not readily available in our context, and as such, we'll have to find out ways of using the above medications, ropivacaine and bupivacaine, while considering that these children actually have immature systems and trying to adapt to their organisms. And all of you, as you know, all the other things you need to consider are the fact that neonates have thinner nerve fibers, they have less myelin, and they have closer nodes of Ranvier, which means blocks are achieved with relatively lower doses. So what options do we have? So this is a list which we're going to go through progressively, and we're going to look at these different techniques. One important thing to note is neonates are human beings like each and everyone, like they're like adults, they're like adolescents, and as such, every possible technique which you can use in an adult can be used in a neonate. But then they are different, depending on the indications for surgery, depending on the ease with which we can do certain techniques. We prefer to focus on these and see what is probably the best option for the neonate we have in front of us. So the first technique I'll think about is spinal, which for me is really one of the best techniques, especially for the small and the little premature children who have an indication for lower abdominal surgery. One thing with spinals is the smaller the children are, the shorter the duration, obviously because of the volume of distribution and probably a higher clearance of local anesthetic drugs in this population. So as such, if you're doing a spinal in a premature neonate, you should consider the fact that it should be a procedure that lasts not up to 15 minutes, because beyond that, you don't have that length of the desired effect, which you would want. And usually these these indications are more in children who have respiratory challenges, especially these premature children who have immature lungs and who have a surfactant deficit, and in whom we fear that if we have to do general anesthesia, we may further compromise their respiratory function and keep them ventilated for longer than we can and have difficulty weaning them off the ventilators. So generally, the technique is using sucrose in a pacifier for sedation, because as much as possible, we want to keep these children breathing spontaneously. Topical anesthesia using our EMLA, or while noticing that we need to consider the risk of toxicity linked to the local administration of local anesthetics, we need to use a short needle, not the long needle which we use in adults. 25 gauge needle is fine. We'll have to target the lower part of the spine, L4, L5, because we know the smaller children are, the lower we have the spine ending. We can do identification either by palpation or by the use of ultrasound. And very important, we shouldn't associate opiate adjuvants for the simple reason that these children present with apnea, but which we'll see eventually as the presentation goes on. So I'm sure you're all familiar with this position, either on their side or seated, as you can see in figure B. And you can see the different doses of local anesthetic used in children quite high. But we know that as we go up to children who are over 5 kgs, we can go up to 0.4, 0.3 milligrams per kilogram, but generally it's 0.5 to 0.6 milligrams per kilogram of bupivacaine. Note that there is no difference in effect between using hyper or isobaric bupivacaine, especially in an African context where these are the main local anesthetics which we have for spinal anesthesia. Caudals are a very interesting option of regional anesthesia, and their indications are generally for abdominal surgery and for digestive emergencies, which we all know are the main reasons for which we often take children, neonates, for surgery. Obviously, neonates are really the perfect candidates for emergency situations. And obviously, if we can move interventions out of the neonatal period, the safer it is with all the airway challenges. As such, we'll have caudals indicated for hernias, complications, emergencies such as bladder exstrophy. Sometimes we can even use a caudal for lower thoracic surgery, such as the tracheoesophageal fistula repairs. And they basically have the similar indications as for an epidural nerve block. So usually the technique is with general anesthesia, which gives you that analgesic aspect and prevents you to use opiates and hence reduce the risk of apnea. Although some teams have experiences with sedation, especially for procedures like hernias in neonates. Usually, caudal needles exist, but IV cannulas are as effective as well. 22 gauge cannulas work. These children are usually positioned left lateral position for right-handed people and vice versa, and the legs flexed, or sometimes some teams prefer to do it prone. Usually, you can be perfectly achieved through anatomical landmarks, although ultrasound guidance can also be a good way of being sure of attaining this, getting into this lower epidural space, which is the caudal space. And sometimes you can have with or without the insertion of a catheter, which we will see in subsequent slides. So this is sort of the anatomical presentation we'll have with caudals, which most of you will be versed with, like the posterior superior iliac spines form an isosceles triangle with the sacral hiatus, which you can see on the left. You can also see the orientation of the needle, which is important. You go in at an angle of 45 degrees to the skin, and then you orient to 15 degrees to actually follow the trajectory of the sacral canal. And in that space, you inject your local anesthetic. So the doses are generally, the higher up the abdomen we are working in, the higher the dose. So we'll go from 2.5 to 0.75 mils per kg for a sacrolumbar block for surgery, which is around the perineal region or the genitalia, to as high as 1.2 milliliters per kg of local anesthetic for lower thoracic or upper abdominal procedures. Although the Asian Society and the European Society of Regional Anesthesia usually suggest not exceeding 1 mil per kg, but several teams go as high as 1.2 mils per kg. I personally use 1.2 milliliters per kg, and I find it quite efficient, on condition that we respect the maximum dose of toxicity of local anesthetics, which is 2.5 milligrams per kg for bupivacaine or 2 milligrams per kg of bupivacaine. We'll have a table later on which details that for all of the other local anesthetics. Obviously, because we're dealing with neonates, we generally avoid adjuvants such as opiates, clonidine, or dexmedetomidine. Now, epidurals would They're usually ideal for heavy and invasive thoracic or abdominal surgery and procedures for which we believe there's going to be a high pain component in the postoperative period, like very invasive procedures. They can either be thoracic or abdominally inserted, like inserted along the spine, and here ultrasound assistance is beneficial, while keeping in mind that for the neonate, the distance from skin to epidural space is about 10 millimeters, so 1 centimeter. Usually would avoid air and use normal saline for loss of rest or resistance technique. Sometimes we can use a caudal insertion, that we have an epidural catheter inserted via a caudal, but usually there are concerns with proximity of the anal region and contamination via our caudal catheter, which will remain in place for quite a while with the child going to stool and all of that. Usually would give a loading dose, which should be slow, and usually is 1.5 to 2 milligrams per kilo of local anesthetic, be it bupivacaine or ropivacaine. And then we have a continuous dose of 0.1 to 0.2 mils per kg per hour. In neonates, because of the flexibility and some sort of space that we have in the spine, there's a higher risk of migration in neonates, which requires that if we're putting an epidural, it's important to have an acute pain service, follow up these children, and be meticulous about the following up the evolution of pain management and the other symptoms which may characterize the migration of the catheter in these neonates. So we can see on the left a caudally inserted, the procedure for caudally inserted epidural catheter. We can see it's ultrasound guided, and on the right we have the classic epidural technique which we all are versed with. Another option we have are paravertebrals, which I find as one of the very interesting techniques from a personal experience perspective. Paravertebrals are ideal for thoracotomy, laparotomy, and pectus repair. They are being increasingly used for minimally invasive surgery such as laparoscopy or thoracoscopy. In cardiac surgery, some teams use them, but there's a bit of controversy because obviously in cardiac surgery with all the anticoagulation, inserting a catheter in that kind of space may show some concerns, but there are some teams that use paravertebrals and usually have a satisfactory pain management scheme postoperatively. Usually a paravertebral can be given as a one shot, or may use a catheter for infusion, and it can be unilateral or bilateral. Obviously, ultrasound techniques are way better than landmark techniques, and usually the dose is 0.5 mils per kg for a 5-meter mean spread. We'll see from the images in the next slide how to get the ultrasound approach. There's usually a very low rate of complications with paravertebrals because it's pretty straightforward technique when there's mastery. And there's quite a bit of a competition right now between the use of paravertebrals and erectospinae blocks, which are more superficial but give a similar effect as compared to paravertebrals. So you can see on the left how we put in a catheter if we want to have a left paravertebral block. You can see the red arrow shows us the orientation of the needle. And with that needle, we see the thoracic paravertebral space on the right, how the needle should come in with our ultrasound guidance, and where just above the pleura here is where we are going to inject our local anesthetic. We should fill up this space below the dotted line. The erectospinae block, which I prefer to discuss at the same time as the paravertebral, we can see here that the orientation is different. It's more of a craniocaudal orientation of our probe, and our needle is oriented in the same plane as our ultrasound probe. And this is our transverse process here. This is our erectospinae muscle, ESM, as abbreviated here. And as we cross the erectospinae muscle, just below its fascia, we will insert our local anesthetic, which will spread and give us a block which unilaterally, depending on the transverse process, left or right, spreads to the paravertebral space beneath it, giving a similar level of a similar degree of analgesia. Now, this is a very interesting option, which unfortunately aren't used by many, but which I find very, very interesting and applicable, because usually it involves the surgeon simply just injecting a dose of local anesthetic into the wound. Wound infiltrations for me are very easily practiced. Anyone can do them on condition that we adapt the volume to the toxic dose levels, which we have calculated based on the patient's weight. They're interesting for procedures such as laparoscopy, where we have just the different points at which the different cannulae go in, and so we just infiltrate local anesthetic at these points. For small incisions like hernia and for short procedures, important to always consider the total dose of local given, including the local doses, the dose of local anesthetic, which some people may give through IV. So we should always consider that if we've given a local anesthetic IV, we should be very careful about what doses we give for infiltration, because all of these contribute to the toxic dose that we'll see in these neonates. Talking about wound, we just spoke about wound infiltration. Wound infusion catheters are, for me, a very interesting option for the management of postoperative pain, because they are very interesting for procedures where we have long incisions, especially incisions that extend over multiple dermatomes. Talking of incisions like, for example, from the xiphoid cartilage down to the pubis, especially when we have to do like massive explorations. The problem in this situation is you can't have a block which covers all of that. And so the ideal way to manage pain in this circumstance is to use a wound infusion catheter, which is placed in between the parietal peritoneal membrane and the muscular aponeurosis. And then the surgeon places that, as you can see on the left, and it's a sort of a perforated kind of catheter, as you can see on the top right, which gradually, when connected to a pump, releases local anesthetic, giving us actually pain relief at the level of the wound, which is actually an important aspect of the postoperative pain that the patients feel. I always think that having buy-in from the surgeons, because it's always happy, I think they're always happy to participate in the management of their patient's pain. It's always a win-win for the patient, is a win for everyone. Post-op follow-up is easy because they just need to check that there's not a leak around the wound infusion catheter, and that the pain, just simply follow up the pain response of the patients to pain. Obviously, we can see the doses there, 0.2 mils per kg per hour, and the different concentrations depending on what local anesthetic we use. And obviously, the differences in the length. We have 2.5, 5, 7.5, or 10 centimeter catheters, which we insert depending on the length of the incision which you have. This is really a very interesting option, which I believe could really help change the way we manage pain in neonates. So talking about surgeons, I always shout out, because I've spoken about two techniques. I've spoken about the wound infusion, and I've spoken about the wound infiltration. Just a shout out to my surgeon colleagues. I remember when we used this for the anesthesia for neonates, I remember my surgeons always complain that there's a lot of heat coming off of them, but I think we sometimes fail to understand that surgeons are also very concerned about the welfare of our patients. So I'll just tell them hello from the other side of the drips. Coming back to the different blocks, abdominal wall blocks, generally when we put in a caudal, it's generally fine, but in situations where we can't have neuraxial blocks, we can rely on abdominal wall blocks like the transverse abdominis plane block and the quadratus lumborum block. These situations in which we use them in place of a caudal are situations like when we have spinal dysraphism or spina bifida, where we cannot do any technique which is neuraxial. We also have the rectus sheath block, which is a simple block which can be used for short procedures, simple procedures like pyloromyotomy or umbilical hernia. The ilioinguinal block offers good pain relief after inguinal incisions, so it will be good for oculopexis, it will be good for inguinal hernia. And subpubic penile blocks are interesting blocks for circumcision. We can also see the volume here, 0.1 milliliters per kg. For extremity blocks, we have the classic brachial, sciatic, femoral, which we would do in adults. These techniques can also be carried out in children and can also be carried out in neonates for the same indications. The simple reason why we may not use these techniques in the neonates is the fact that in the neonatal period is generally life-threatening emergencies that are operated upon. So generally our digestive emergencies, our thoracic emergencies, and probably our neurosurgical emergencies. So rarely will we be in a situation where we have to operate on a neonate because of a deformed limb or something. That's why most of the time these blocks are not used in neonates, not because they can't be used, but because simply the indications are narrowed down to what is essential for the survival of these children. The advantage even of using these techniques is there's easier diffusion than in adults. Remember, we've said they have closer notes of Ranvier, and they have a thinner myelin sheet. So they are excellent blocks obtained with relatively lower doses compared to adults. Now, what should we be careful about? We've gone through the whole range of techniques from neuraxial to abdominal to whatever, to extremity blocks. What should we be aware? If there's one thing we need to retain is we have said that children with metabolizing local anesthetic. So it's important to detect local anesthetic systemic toxicity. You can see above that's the normal ECG trace, which we'll have, and below we can see that there's already a modification of our ECG rhythm, ECG tracing. It is very important, thus, to have proper follow-up, having an ECG connected, even if we're doing a procedure as simple as a spinal. Well, let me not say as simple as spinal, but a procedure where we think, well, there's no GA, but we should have monitoring to be able to detect the signs of toxicity. It is very, very important, and to have the means possible to manage local anesthetic systemic toxicity. We should be aware also of failure, and failure would obviously be detected by probably pain on incision or a very uncomfortable neonate with all the pain evaluation techniques which we would have. So it's important to think about failure and have a backup plan if we have a failure in our technique. Very important is postoperative apnea, with risk factors being prematurity and anemia linked to opioid use in general anesthesia or adjuvants of regional anesthesia. Very important to note. It's not because we have put the adjuvants in the mix with the local anesthetic that it stops it from having the effect of postoperative apnea. As such, it's preferable to totally omit opiates as much as possible. And obviously for other causes such as prematurity and anemia, we'll give aminophylline and caffeine, depending on the indication, and we'll treat any anemia in the neonate. It's also important to know that at some point, because we're doing injections with needles, we can always cause organ lesions, and as such, our ultrasound is a very good aid to guide us to have like a visual, to visualize where a needle is going to, and to avoid having organ lesions in these fragile beings. What other precautions do we take? Ideally, we should perform regional anesthesia in an anesthetized children, in an anesthetized neonate. It is very, very important to consider their comfort. The only exception is in spinals, premature babies, where obviously we're doing the spinal because we want to avoid a general anesthetic technique due to the immaturity and due to the high risk of apnea in this population and their fragile lungs. Sedation options, I insist here that we should respect institutional recommendations, which should be clearly defined and protocolized. I say this because it should be a clear organization. Everyone should know the role, should know what should be done for any particular procedure, such that if there are any complications, they can be easily managed, rather than leaving it to the discretion of any practitioner to do what they want. So having a protocol, having a clearly defined recommendation is very, very important. Now, other sedation options, some teams use IV ketamine, IM ketamine, sugar dummies work very well. Some teams use carefully titrated propofol. It depends on what the different teams are comfortable with, but there should always be a sedation option when carrying out the regional technique. And most of the time, this regional technique should be in association with a general anesthetic technique, covering the analgesic aspect. Ultrasound should be used as much as possible. I would even say that for every technique used in the unit, because we're dealing with a small being with anatomy which is really very precise, ultrasound is one of the only ways in which you can assure efficiency to avoid all the complications that we have stated before. And the most important precaution is beware of toxicity. Always calculate the maximum acceptable doses for the population that we are dealing with. That's why I put up this table, which brings out the different toxic doses which we have for the individual local anesthetics for a single injection and for a continuous diffusion. These are the, in the middle column where we have continuous diffusion, these are the maximum infusion rates which we should consider when administering local anesthetics. And on the left, we have for single injection for single bolus doses. So depending on the different technique that we're managing and depending on the local anesthetic which we're using, we should consider that these are the limits which we should keep very, very far away, and we should try to maintain the children within safe limits by always calculating respect to their weight. And this is valid even when we are doing our wound infiltrations. Not because we're doing a wound infiltration that we should say, well, if the surgeon wants 10 mils, we give him 10 mils of local. No, give him 10 mils of local, but the 10 mils of a mixture, making sure that the quantity of local doesn't exceed the single injection bolus dose that we have. And if we're running an infusion, we should always respect these toxic doses to avoid having to manage local anesthetic systemic toxicity, especially in the context where we know that we have difficult access to intralipids, which are the ideal treatment in local anesthetic systemic toxicity. So prevention for me is better than cure. So as a spokesperson for these babies, I imagine right now these little, excuse me, and fragile beings are watching us from those theater tables, and they're telling us we are fragile, we feel pain too, we want blocks whenever possible. In fact, wherever there's a nerve, block it, keep us comfortable. Please don't give more than our little bodies can metabolize, meaning we need to calculate the doses before we give to them. Make us sleep before you prick us, except the premature ones for spinals, which we've discussed. And to be efficient, please, we should use ultrasound. So I think if we can take back these 6 points, we'll be able to give safer anesthesia to our little babies, make them more comfortable, and be better anesthetists and give better quality of care. So these are a few references which we use for our presentation. And thank you very much.
Thank you so much, Raymond, for the brilliant and beautiful presentation. What a comical way to complete that presentation. You made me feel like a neonate again, as if I knew how I felt that time. We have questions on the chat box, which I want us to quickly, on the Q&A button, which I want us to quickly address. One is coming from Dr. Adams, and the question is, how can one monitor the spinal anesthesia block height in units? So be glad if you can kindly attend to that.
Okay, thank you, Dr. Adam Salis, for your question. How can one monitor the spinal anesthesia block height in units? The fact that we're doing spinal anesthesia doesn't stop us from doing the classic monitoring that we'll have, perioperative monitoring, meaning we'll see our ECG on, we'll still have our pulse oximetry, we'll still have our blood pressure measurements. The good thing about spinal anesthesia in children overall is that the advantage is children have the sympathetic nervous system isn't well matured and developed, and as such, spinal anesthesia will not give us the classic drop in blood pressure which we have in adults. That's one thing. But then the spinal anesthesia block height usually becomes a problem when the block is high enough to give respiratory compromise, and at that point, it'll be important for you to have your end-tidal carbon dioxide monitoring to see how your patient is breathing, to see that they have a regular respiratory rate. And also with your ECG monitors, you'll be able to see that there is, with the impedance monitoring, you would see that they are breathing and that the oxygen saturation is okay. So it's only at that point where you can be able to say, look, if the block is high, this is where I'm going to go. The other thing also is respecting the doses, staying within the 0.5 milligrams per kg or the corresponding volume doses. I think that is the best way. Clinical monitoring of the way we've given the spinal is one of the only ways that we can monitor the block height in units. But generally, it's a safe technique, provided we respect the doses given to these children.
Very much. Dr. Raymond, you can see the questions in the chat. I don't know if you can just attend to one more.
Yes.
Live here.
Yes.
Then other ones, maybe if you can type this presentation still on.
Yeah.
Okay, because of our time. Let's just take one more.
So I'm seeing a question here by Adamu Yusuf, who is asking, Did I get you right that the smaller the child, the faster the rate of drug metabolism, and no difference between hyperbaric and hyperbaric solution? Yes, that is true. The smaller the child, the bigger the volume of distribution, because the smaller the child, the higher the water content. And as such, there is a more widespread, that you have a lower concentration in that entire volume of distribution. And it's not necessarily the faster the rate of drug metabolism, but simply the fact that the drug is more widespread and you have a lower risk relatively in terms of toxicity, because the drug spreads out to a bigger area, and so you have a lower concentration in the blood. So it's not that the rate of drug metabolism is higher. Secondly, in terms of hyperbaric and hypobaric solution, and isobaric solution, not hyperbaric, there's generally no difference in the effect or the quality of anesthetics, of anesthesia in these students, especially because the spinal space is really very small and such. You don't get the difference with respect to the density of your local anesthetic, which is injected. I think that should be it. And then he asked a question about bupivacaine toxicity in neonates. I think essentially the toxicity of local anesthetics is the same. You have cardiac signs and you have respiratory signs, you have neurological signs. That is why you need to keep like a constant follow-up of your child. If you're doing, if you have a child who is under general anesthesia and in whom you inject local anesthetic, you should have ECG monitoring, because you would have signs of changes in your ECG tracing, and it's through that and through other signs, like for example, a child who's presenting body movements, which can be witnesses of convulsions. Those are the clinical signs that you would look at. But I mean, to avoid toxicity, respect the doses, and to detect, make sure you look at your ECG tracing and you are alert for other signs which are neurological and maybe hemodynamic, like your drop in your blood pressure, your increase in your heart rate, which will be signs of your toxicity of your local anesthetic.
Thank you very much, Dr. Raymond. The other questions will be answered through typing. I think we can refer to that later. Once again, I want to appreciate you for making out time to be part of this event and for delivering that beautiful presentation. Thank you very much.
Thank you.
This moment, we want to go ahead to the lecture 2, when things go wrong, critical event debriefing. And we all agree with me that things often goes wrong. And the most important thing is you don't know when they will go wrong. But what do we do? What will be our approach in this often unpreventable event? To help us, or to do justice to this topic tonight, we have in our midst Dr. Rebecca Gray, a specialist pediatric anesthetist from Red Cross War Memorial Children's Hospital, and also a faculty at the Department of Anesthesia and Perioperative Medicine, University of Cape Town, South Africa. You are welcome. Dr. Rebecca Gray, you have the floor.
Thank you so very much. I'm going to share my screen, and let's hope that that's where we are. Can everyone see my screen? Just a thumbs up will be good. Okay, I'm going to take that as a yes. So first of all, I just want to bring you greetings and congratulations from the pediatric anesthesia community of South Africa on your first anniversary. And we wish you many years of growth and good work. And thank you to my new and dear friend, Prof. Ronki Desalu, for the invitation to speak to you all. Raymond is a hard act to follow, and I hope that you are not disappointed by the fact that my talk is going to be distinctly non-academic, but I hope it will be helpful, and I hope it will give you some food for thought. I just want to start off with some quick disclosures. These are organizations and institutions who I work with or who support my work in peds anesthesia and in simulation training. So I want to start off with a story of something that happened to me in the early 2000s, so a good few years ago. I really shoved it far back into my subconsciousness, but I was reminded of it a few years ago as I first began to be drawn into the work of debriefing in theatre. I was fresh out of my final college exams for anesthesia, and I was working on a burns list at my hospital, at the Children's Hospital, with a senior specialist. Now, just after starting the case, the specialist stepped out of theatre. And shortly after that, the surgeons turned the patient over to clean his back. He had extensive burns. And in the turning, the pulse oximeter came off my patient. I found it and I tried to reapply it, but the patient was terribly slippery from all of the cleaning, and the strapping wouldn't stick that was holding the pulse oximeter on, and I couldn't get a reading. And so I kept trying while the surgeons were busy cleaning. And then finally, I realized that the patient had actually been extubated during the turning and was in fact apneic. I got everyone's attention. We turned the patient over, but by that stage, he was deeply cyanotic and actually he was asystolic. So the alarm was raised. My senior came rushing back in and reprimanded me for not calling earlier. We resuscitated the patient. We got a return of spontaneous circulation, and we sent the child to the ICU intubated. I was reprimanded and the list continued. I assumed full blame for the events, but I didn't talk about it. I comforted myself with the fact that as soon as my carelessness became public, I would be struck off the practitioner's role, so I wouldn't be a danger to any more patients. I asked quietly what was happening to my patient, and on day 2, he had a seizure. I wondered whether I should resign because nothing was happening. I wondered whether I should voluntarily hand in my license to practice. I felt like all my colleagues were talking about me. Every case I did felt unsafe after that. Until 2 weeks later, I went on holiday and I found the space and the time to talk to my husband, who's medical and could to some extent understand. So I'm wondering, how many of you have ever experienced a critical event in your work? From the introduction, it sounds like I'm not alone. Maybe it was a time when, despite your best intentions, things didn't go as you had planned and hoped, and possibly they even went wrong, and the patient came to harm. Maybe it was just a very bad situation for the patient already, and you weren't able to save them. Maybe it was expected, maybe it was unexpected. It doesn't even need to have been something that you felt you were responsible for. Perhaps it was just a situation that you were in charge of. Perhaps you just came in to help. Maybe you were even just witnessing it from the outside nearby. And now I'm wondering, for those of you who have experienced a critical event, did you have a conversation afterwards with your team? Did you all get together and talk about it? So to have these sorts of conversations, I first need to talk about a no-blame culture. And a no-blame culture is built on the positive belief that workers in our industry, that's the healthcare industry, all want to be fully participating members of high-performing teams, the teams that we work in. No one comes to work with the intention of doing a bad job. A no-blame culture is important in a workplace like ours because small errors can have catastrophic consequences. And because errors can be so catastrophic, it's dangerous to work in a space where you don't feel able to raise concerns or report errors, and to raise concerns about things that look as though they may turn into an error in the future. So a no-blame culture embraces the possibility of errors. It says errors are possible in our workplace, and it encourages their reporting. On to debriefing. Well, the World Health Organization defines debriefing as the process of an individual or a team formally reflecting on their performance after a particular task, after a shift, or after a critical event. And it turns out that many organizations are advocating for debriefing as a way of enhancing team performance and improving patient safety and to foster physician well-being. So in this context, I want to explore how critical event debriefing can help teams to function better together and how individuals can be constructively supported following a devastating event. When we have a critical event, you get your first victim, and that's the patient. And then there's the second victim. That's the clinician. Maybe a nurse, it may be a surgeon, it may be a physician, it may be an anesthesia provider. And then there's the third victim. And those are the future patients. All of these deserve to be protected. So our systems and our work ethics should protect the patient, but we know sometimes they don't. By holding a debrief, we can support our second victims, and hopefully we can prevent that third victim from happening. In my experience of a critical event, the facts are not clear to everyone. And piecing together the events to come to a common understanding of what's happened is a very important part of dealing with that event, especially for juniors who are in the realm where the event is happening, junior doctors, nursing staff perhaps, who don't understand necessarily what's gone on. It's very easy and it's tempting to speculate as to what's caused the event before the facts are known. And immediately afterwards, we're often trying to understand it and we're often jumping to conclusions. We need to try and avoid this, or at least be clear with everyone that that's what we're doing, that we're speculating, and then commit to communicating the facts once they are known, but especially when you've had a really bad event, for example, a death, and where a post-mortem may be able to give us a few more answers. Communicate to bringing those answers back to people. Right, so when should we hold a debrief? Which events should we debrief? It can be quite difficult to define, actually. So the Talk Foundation recommends debriefing all near misses, serious untoward events, any expected or unexpected morbidity or mortality that happens. And then you would have pre-agreed triggers. Death, for instance, in pediatric anesthesia, maybe any death that you have in the table, anytime CPR or any other form of resuscitation takes place, or other triggers that you may have identified in your context. For example, anytime a massive transfusion is activated and performed, maybe those are events that we need to debrief and understand. The Talk Foundation and I also recommend debriefing other situations, including when things go well. Let's get curious about when things go well. How did we manage to get it right? And this can often inform how we can get things right in other settings. Who can ask for a debrief? Who's on your team? Well, any member of a team should be able to ask for a debrief, and your team is often much bigger than you think. It's anyone who was around when it happened. So in our context, that's going to be us, the anesthesiologists, the surgeons, the nurses. Maybe it's a bigger team. Maybe it includes interns, medical officers. Perhaps the porter became involved. Maybe the cleaner was around. Maybe it's the ward administrator, the medical technologist, the laboratory, the blood bank, the hospital administrator. Your team might be quite big depending on the magnitude of the event. When should you do it? Or what time should it be done? Ideally, it should be done immediately after the event, as soon as possible, as soon as the patient's safe and our attention is no longer needed on them. And it should ideally happen before we take care of the next patient, because they may become the third victim. It's not always possible, but this is what we should strive for. And if you are able to do it this soon afterwards, it doesn't actually need to take that long. Just enough time for everyone to acknowledge their feelings, to gain some understanding of what's happened, and to identify any latent or actual system threats that need to be addressed right away, and to see whether people are all right to keep on working. I call this a hot debrief, and it's about containing the emotions and coming to a common understanding of the events. I also conduct cold debriefs, which are for really complicated or serious cases, once all of the facts of investigations and reports are in. And it's more of a root cause analysis. It almost always needs the team to have been through a hot debrief for the emotions to have been contained before they can think clearly to go through a root cause analysis. How do we do this? Well, there are several tools available, and these are just a couple of them available to help you with this process. And I'd recommend looking around, looking at a few to see which ones are going to work for you and which one fits your setting. And you need to strike a balance between emotional support and system learning. Both of them are important in a debrief. Some of the tools are a little bit more touchy-feely, and others are very focused on team and systems learning. If there has been a devastating outcome rather than a near miss, then you definitely need to find a way for creating space for psychological or post-traumatic support. Sometimes it feels easier just to let someone go home after a devastating event to recover, but the evidence shows us that this is not the most helpful way to deal with it. Certainly, they shouldn't be patient-facing immediately afterwards if they're feeling severely emotionally traumatized or uncontained. But what you should probably be doing is keeping them at work, occupied with non-clinical tasks so that you can keep checking in on them and support them further. I check in on who they've got in their lives who might also provide support for them. It could be a family member, it could be a religious leader, it could be a close friend or a mentor. So I'm going to go back to my case. So clearly I've moved on. I've embraced a career in pediatric anesthesia. But I can tell you that what I needed at the time, didn't even know it, was for someone to take me aside and to check in how I was feeling, to hold my feelings and to see how I felt about continuing to work. I needed them to unite me with the rest of my operating team, with the nurses, with the surgeons, so that we could all come to a common understanding of what went on. I'm willing to bet that those nurses and surgeons felt pretty much as bad as I did about that child. But I doubt that we all understood what had happened and the hows and whys of it. So I'm going to give you a quick rundown of my version of the debrief in the context of my story. These are the way that I would have liked things to have turned out, and if I was a senior and it had happened to my junior. So the first thing I do is I gather everyone together. We find a space as near as possible to where the event has occurred, just to stop losing people along the way, and hopefully immediately afterwards. Gather the team, and it must be private and quiet. And I start by checking in on feelings and acknowledging my own. That was a really tough situation. I'm feeling sad about how that unfolded. How's everyone else feeling? And now I'm going to look around, and I'm going to allow for some silence and allow people to fill that in. Don't push anyone to say anything, but just give a little bit of time. And I've shown my vulnerability as well. Next up, we're going to get on top of the facts. Sorry, I'm managing two screens here. And we're going to put the facts together by asking someone to summarize what happened clinically and getting people to supplement until I'm satisfied that we've all come to a common understanding. I'll put it all together at the end and reflect it back to them. And it might look something like this in the context of my event. Okay, so if I'm just going to summarize what you guys have said, we've had a 5-year-old child with extensive burns for grafting. Shortly after induction, they were turned prone, and in that maneuver, the single monitor and the ET tube were dislodged. In attending to the monitor, that was difficult to reapply because the strapping was wet. Anesthesia was distracted from the extubation. The rest of the team were busy with the procedure and unaware of what was happening with anesthesia. The patient was apneic for a period, which led to what was most likely, just to emphasize that I'm speculating there, hypoxic cardiac arrest. Resuscitation was instituted speedily. Return of spontaneous circulation was achieved rapidly with the participation of the whole team. Have I got that, guys? Does anyone want to add anything in there? So I'm just checking in to see that everyone is comfortable, that that is a good summary of the case and we're all clear on the facts. Next up, I want to see, were there any obvious system issues that we need to address? For example, it could be that there was some faulty equipment that contributed to an event. Using my case as an example again, I might say, right, I think we need to look at our communication around position changes in theatre, as well as at our strapping technique for monitors in these large body surface area burns. And then you need to allocate these tasks to specific people. So I'm going to go, Ronki, I'd like you please to look at that communication piece and how we can better communicate around turning and around the safety checks there. And can you let me know your thoughts so we can communicate that to the whole theatre? And Raymond, I'm going to ask you please to review the way that we're strapping our burns monitors on to see if we can come up with a safer way to do that. So I've allocated the jobs to specific people and fed that back to the team. That's quite motivating to see that change positive change may come out of a tragic event like this. Okay. coming to the end of this part of the debrief, and we'd say, right, I'm going to check in on the feelings again at this point. So guys, I just want to check in. How is everyone feeling now? Again, a little bit of silence, wait for people to say what they're feeling. And we need to make a plan going forward. We've got a list, we've got 2 more cases to do. So I'm going to check in to see whether the team or the individual members of the team feel that they're okay to carry on, or perhaps they need a little bit more time before they assume clinical duties. And I need to, at this point, check in. Does anyone need more emotional first aid than what I'm capable of giving them? And I would urge everyone to acknowledge that they're not, unless they particularly are, they're not necessarily trained professionals in giving emotional and psychological debriefing, and that is a specialist skill. What we're applying here is some emotional first aid, and beyond that, we need to recognize when people need more than just that, and particularly when it's been a devastating event. So check in who's able to carry on. So I would say, right, guys, we've got 2 cases left on our list. And I just need everyone to just have a think about, are they okay to carry on? Does anyone need to take a little break? And then we'd make a plan going forward. So that's really how I do my critical event debriefs in a nutshell. That's not an instructional course that I've given you. It's just a taster. Again, there are several different options for you of published scripts and so on. I will absolutely share those with you so that you can have a read of those. Just one final thought there is, when you start to get involved in this incredibly rewarding work, it can also be pretty draining. And if you're doing a lot of debriefing, you may become quite emotionally overloaded. So do look after yourself first so that you can look after other people as well. And this is really the spirit in which this talk is delivered, is we are learning and we're improving together. And let's build a supportive culture of safety in healthcare. This can extend way beyond our theatre work into our whole the healthcare systems that we work in. I want to finish off just by plugging an event I hope to see you all at, and that's the All Africa Congress. That will be in South Africa in September next year. And let's hope that we can have the first meeting of the African Paediatric Societies of Anaesthesia. So thank you very, very much. I'm going to stop sharing now, and I'm ready to have a look at what you've been popping in the chat.
Thank you very much, Dr. Gray, for your presentation. So quickly, let's go to the chat. The question and answer button. Do we have any question for Dr. Gray? Meanwhile, the previous questions are being answered by the first presenter. So they look into that and check later. I've tried to check. I don't think there is any fresh one. When things go wrong, critical event debriefing. Okay. Because of our time, I think we need to proceed. If anyone comes up, we want to please plead with Dr. Rebecca Gray to help attend to that. The next thing
Thank you very much.
Thank you very much. The next thing on our agenda is goodwill message. Goodwill messages. We have messages from some of our partners, and to deliver their message this evening, I want to invite Dr. Dati Mohammed, a very member of Paediatric Anaesthesia Society of Nigeria, to help deliver the message from our partner. Dr. Dati, sir.
Thank you very much, Aaron. Can you hear me?
Yes, I can hear you, sir.
Okay, thank you very much. Let me try to share the screen. I hope I'm enabled. And okay, sorry. Can you see my screen?
Yes, I can see your screen.
Okay, So I have 3 goodwill messages from very important professional societies. The first one is from Pediatric Anesthesia Society. Yes, from the Society of Obstetric
anesthesia. That's
Anesthesia of Nigeria, SOAN. I write on behalf of the Society of Obstetric Anesthetists of Nigeria to felicitate with the Pediatric Anesthesia Society of Nigeria, PASoN, on this auspicious occasion of its first anniversary. We are aware that this event will be celebrated with a virtual mini conference on Saturday, 9 September 2023. The theme of the webinar, Making Pediatric Anesthesia Safer, is very apt. The faculty of excellent speakers from all over the world is a testament of the high level of collaborations your association is known for. This is a landmark moment for your young and fledgling association. We therefore join others to wish PASoN a very successful 1-year anniversary celebration and more giant strides as they step forward in growth and progress. Happy anniversary. It is signed by the President, Professor Elizabeth Oboli-Nwaso. Thank you very much. I will read the next one. If you permit me to share the screen. Just a minute. Sorry. I hope you can still see my screen. Thank you. Now, and this is from the Pediatric Anesthesia Training in Africa, PATA. On behalf of the PATA Collaborative, I would like
to open the link.
Oh, it's not open? Can you see? Can you see my screen?
I can see your screen, but not the lecture. Will you want me to share from my hand here?
Yes, you can, please. Thank you. Are you making progress? Okay. Thank you. So I hope we can all see this. So if you just scroll up, okay. So this is from the Pediatric Anesthesia Training in Africa Collaborative. On behalf of the PATA Collaborative, I would like to congratulate you on the first anniversary of the Pediatric Anesthesia Society of Nigeria, PASoN. The work of the society, guided by your leadership, is vital to improving perioperative care for children in Nigeria. We are immensely proud of your efforts to advance the profession of pediatric anesthesiology in your country and are hopeful that PASoN will become a model that others in the region may follow. We look forward to witnessing the continued success and growth of PASoN for many years to come. Once again, congratulations on this momentous achievement. Warmest regards, signed by Mark W. Neaton, on behalf of the Pediatric Anesthesia Training in Africa, PATA Collaborative. And there's the last one that I have from NSA, I think. Yeah, thank you. Right, so this is from the Nigerian Society of Anaesthesia, Nigerian Society of Anesthetists, NSA. On behalf of the Board of Trustees, the Executive Committee, and the distinguished members of the Nigerian Society of Anesthetists, NSA, this congratulatory message is sent with pleasure to the Paediatric Anesthesia Society of Nigeria, PASoN, on the occasion of its first anniversary. PASoN has no doubt achieved great strides within this period, and NSA wishes her continued impactful strides. Long live PASoN. Yours faithfully, Dr. Olubusola T. Alabe Briggs, President, and Dr. Saidi Yusuf Yakubu, General Secretary. Thank you. So we thank you all for these goodwill messages. Thank you, Aaron. Back to you.
Thanks to Swan, Pat, and NSA for their goodwill messages. We have a video from Smile Train. Let's kindly share that now. Can anybody hear this?
I can't hear the audio. It's not audible.
It's not audible. Do we? Okay. Because of our time, let's put on hold on that and move straight to our next item. Challenges. That's the third lecture, Challenges and Successes of Pediatric Anesthesia in Nigeria. That's a talk to be presented by Professor Olushola Kushimo. She's a grandmother in the field of anesthesia, particularly pediatric anesthesia in Nigeria. She's one of the board of trustees of Paediatric Anesthesia Society of Nigeria. Professor Kushimo has had her pediatric anesthesia specialization in 1990 at the Royal Children's Hospital in Manchester. She's the first fellow to be trained in the Faculty of Anesthesia at the National Postgraduate College of Nigeria. She had her FMC in 1984. The past chairperson or chairman of the faculty of the National Postgraduate Medical College of Nigeria. She's a trainer of trainers who have contributed immensely to anesthesia generally and pediatric anesthesia in particular. And the Lagos University Teaching Hospital, LASUT, FMC, and of course, all over the country. So it's a pleasure to have you around tonight. You have the floor as we listen to the next lecture, Challenges and Successes of Pediatric Anesthesia in Nigeria. You are welcome.
Thank you so much, Dr. Aaron, for that introduction. And thank you, the organizers, for asking me to speak or participate in this webinar. As you just heard, the title of the talk is The Challenges and Successes of Pediatric Anesthesia in Nigeria. Nigeria is the most populous country in Africa, with an estimated population of about 315 million in 2022. Children below the age of 15 constitute about 41.39%. That is 7.4 million of this number. In 2015, the WHO, the World Health Organization, and member states recognized surgery and anesthesia as an integral and indivisible component of a properly functional health system. And people should have access to high quality surgical and aesthetic care. The vision of the Lancet Commission on Global Surgery thereafter was universal access to safe, affordable surgical and anesthetic care when needed. Despite this, about 1.7 million children and adolescents still lack access to surgical and anesthetic care worldwide, with many residing in low and medium income countries. In most of these countries, Nigeria included, attention had previously focused mainly on primary health care, which is highly recommended because of the burden of preventable diseases. Many of these children who require surgical and anesthetic services, many of these children also require surgical and anesthetic services. The burden of diseases that require surgery in Nigeria is substantial. It has been estimated that 2.9 million children require surgical and anesthetic care in Nigeria. Access to healthcare centers that can provide adequate surgical and anesthetic services is not only poor, but imbalanced, with many of such centers located in urban areas. It has been noted, therefore, that 87.1% of our children would not reach such healthcare facilities within 2 hours. This is very much below the Lancet Commission on Global Surgery target. The outcome of pediatric surgery and anesthesia in low and medium income countries like Nigeria has also been reported severally to be much poorer than the high income countries, suggesting that not only access, but also the safety and quality of perioperative care continues to be a problem. I will therefore try to highlight the challenges we face in Nigeria in providing safe pediatric anesthesia for our children and successes we have gained so far. So what are the challenges? Our challenges are multiple. They range from manpower and workforce shortage, inadequate lack of working equipment, paucity of medication, dilapidated infrastructure, poor basic infrastructure, inadequate resources for healthcare funding, training, and research. Now, let's take manpower. We are all aware that there's a dearth of anesthetic manpower globally. And in our sub-region, the shortage of physician anesthetists is well known, with ratios of about 2 and 2.5 million, 2 and 2.5 per million population in Ghana and Nigeria respectively. Approximately 1,500 anesthetic providers are stated to be rendering healthcare service in Nigeria in 2019. Provision of anesthetic care for children demand a set of clinical skills because of the peculiarities inherent in children. These demand special training of anesthetists who will specifically address these problems. Shortage of pediatric anesthetists constitutes a major challenge in provision of anesthetic care for children in Nigeria. The Nigerian Society of Anesthesia Directory 2016 registered 208 specialist anesthetists as members. 13, which is 6.3%, claimed they were pediatric anesthetists. The unpublished data of an online survey in 2021 by Gisalu and Osazuwa via a link on the NSA group found that the number had doubled to 26. Only 15.3%, had any formal training in pediatric anesthesia. That can be seen, let me see. This can be seen on this slide, where we can see that most of the anesthetists are located in urban areas. You can see Lagos, Ibadan, Port Harcourt, and this is Kaduna, and some of the northern states. These locations are also, they're in tertiary centers in the big cities. Because of the complexity and poor general condition of many of the children coming for surgery, especially emergency procedures, there's no doubt that the skill and competence of the anesthetists is a major contributing factor in the outcome. In the pediatric surgical outcome study, mortality in sub-Saharan Africa was much higher than in high-income countries for the 5 surgical conditions studied. The highest mortality was in neonates, 41.9%, and gastroschisis, 75.5%. This study was carried out in 1,407 children from 51 hospitals in 51 countries. The actual mortality figure will be actually higher since most of the data came from urban cities. As Nigeria contributed 649 patients from 20 hospitals, these results can be taken as representative of what obtains here. Inadequate skills of the anesthetic provider and lack of required equipment were major factors. Shortage of pediatric anesthetists therefore constitutes a major challenge in the provision of quality anesthetic care for children in Nigeria. Most of our providers are general anesthetists, and in a lot of places, anesthetic nurses. This is a major issue that has to be addressed aggressively. Concerted efforts to bridge this gap has, however, commenced. There are very few local anesthetic training programs of ground, and subspecialization in anesthesia continues to be a mirage. There are only 2 fellowship training programs in Nigeria, one by the National Postgraduate College of Nigeria, and 2 by the West African College of Surgeons. Both provide for a 4 to 5 year training for the fellowship and 1 year diploma program and certificate for by both colleges. The WACS has, however, commenced another 2 to 3 year membership program. All these training programs have some exposure to pediatric anesthesia in their curriculum. These continue to supply Nigeria with a flow of physician anesthetists at various levels, but at a very slow rate. For example, since training commenced, Nigerian National Postgraduate College has produced only about 271 fellows and 61 diplomates, while the West African College of Surgeons has produced about 400 fellows. And these fellows are from the West African countries. A major issue following the available anesthetic workforce now is the local workforce migration to the developed countries, the brain drain, or what we call the Japa syndrome in Nigeria. The rate of which this is occurring is becoming alarming these days. And if efforts to reduce it does not take place, it may lead to a total collapse of our whole health system. The main reasons for the migration are poor remuneration, which has been worsened recently by the devaluation of our currency, inflation, poor working condition, and lack of working equipment. Perhaps in the interim, the few available anesthetists can be empowered with appropriate skills to enable them provide safer anesthesia care for these children. Other additional workforce required to enhance or assist anesthetists are the nurses, especially ICU nurses, anesthetic technicians. These also are in short supply, and they play a significant role in the post-operative care of these children. Next, we have inadequate lack of working equipment. This continues to be a major setback for most low-income countries like Nigeria. The resources for most working equipment are lean, and so special equipment needed for addressing pediatric issues, e.g. pediatric ventilators, monitors, and consumables are usually not available. In a survey among pediatric anesthetists, 73.1% stated that they had appropriate anesthetic equipment for Nigeria. This was carried out by Desalo, Inore, and Osazua. And they found out that 73.1% stated they had appropriate anesthetic equipment. But most of the respondents were from tertiary institutions who benefited from a special government intervention between 2003 and 2013, the VAMED, if you all remember. Obviously, this is not a representation of what is happening in most hospitals in the country. Next, we have paucity of, next we have dilapidated infrastructure. Most hospitals in Nigeria are in a state of disrepair. The theaters, the wards, ICUs, and other areas need urgent repair. They create poor working conditions for the practitioners. And like I said, it is one of the reasons for emigration of many of our doctors. The next is poor basic infrastructure. Most of our basic infrastructure are poor or inadequate, and it's a major challenge in most low and medium income countries, and Nigeria is not an exception. Access to medical facilities is often compromised by poor roads, transportation, communication, while inadequate electrical power and water supply contribute to the quality of care provided. Many patients travel long distances to their health facilities, and so ambulatory service becomes difficult. A study carried out in Lagos on 112 children scheduled for day case surgery to investigate the impact of some perioperative criteria on their blood sugar levels shows that 31% of all children assessed were hypoglycemic at 8 a.m. on the morning of surgery. The average distance traveled was 14.8 kilometers, mostly by public transportation. This also causes delay in presentation, which, coupled with the poor general condition of most of these patients, produce a very sick child who will then necessarily require the skills of a pediatric anesthetist. Paucity of medication. This is another major challenge. Most anesthetists work in centers where most of the required drugs are not available. Oftentimes, when these drugs are available, the patient may not be able to afford them. Most patients in low-income countries are poor and cannot afford to pay. 40.1% of Nigerians are poor, according to the National Poverty Line 2018-2019. An estimated population of 88.4 million Nigerians lived in extreme poverty in 2022. Payments for services and medication is often out of pocket as coverage of the National Insurance Scheme is abysmal. The next challenge we face is inadequate resources for healthcare funding, training, and research. Government expenditure in Nigeria on health is quite low. Only 3 to 3.8% of Nigerian GDP is invested in the health sector. This is very much below the recommended WHO average of 15%. It is therefore not surprising that the healthcare system in Nigeria is still at the poor state. There is very little provision for training and research. Government must seriously look into this and change its policy for a positive change to occur. The Lancet Commission on Global Surgery, with its vision of affordable and safe access to surgical and anesthetic care service to every patient when needed, also reaffirms and states that investing in surgical services is economically affordable, saves lives, and promotes economic growth. Without a scale-up of the investments in the surgical field, low and medium income countries will continue to experience losses in the economic productivity. And these losses have been estimated to be around $12.3 million between 2015 and 2030. Now, it has not all been challenges all through. We have managed to record some successes, and I have tried to group them into global attention to surgical and anesthetic care, new perspectives, initiatives in training, infrastructural development, contribution of professional bodies, and visibility of Nigerian anesthetics on the international global scene. Let us look at the global attention to surgical and anesthetic care and solutions. The global recognition given to surgical and anesthetic care as component of universal health care by WHO in 2015, I would consider as the first major success, because it has paved way for solutions, especially in the improvement of surgical and anesthetic services for children. Other global organizations that have contributed to safe surgery and anesthesia in children include the Lancet Commission on Global Surgery, who provided strategies, targets to achieving universal access for safe, affordable surgical and anesthetic care when needed. The G4 Alliance developed consensus indicators for strengthening global surgical systems, even though children were not mentioned, but it can be applied to children. Such indicators include some access to timely surgery, quality of surgical care, financial risk protection. Then we have the National Surgical Obstetric and Anesthesia Plan, NSOAP, which provided guidelines to receiving core surgical benchmarks necessary for universal health coverage. It is essential that pediatric surgeons and anesthetists, leaders skilled in care of children, be involved at the highest level. Nigeria is one of the few countries that have keyed into this. And thus we have the National Surgical Obstetric Anesthesia and Nursing Plan in Nigeria, the NSOANP, which have tried to address the surgical needs of children by putting up strategies which include increasing the workforce for children's surgery, and including staffing and training and creation of children's hospitals. This is a significant progress, and if successfully implemented, will facilitate safe surgery and anesthesia for our children. We also have the Global Initiative for Children's Surgery, which produced the Optimal Resources for Children's Surgical Care document. And the documents include the need for more training opportunities for pediatric anesthetists, basic anesthetic equipment required for each level of healthcare, and data collection at national level. So if all these are implemented, as I said, then we'll be moving near to achieving what's our goal, our target of providing safe anesthesia for our children. Then we have the new perspectives and initiatives in training. Now there is more concerted effort globally to bridge the gap in the training of skilled anesthetists workforce. The training of these specialists is often long. Therefore, more efforts are now directed on local training of the general anesthetic practitioners on the ground. Nigeria is now benefiting from some of these programs, and this is a significant progress. We have post-fellowship training programs. The first is the WFSA, World Federation of Society of Anesthetists, Pediatric Anesthetic Fellowship Training Program, which was designed to train a cohort of physician anesthetists who will become leaders and educators to train others and champion the development of pediatric anesthesia as a subspecialty. This was commenced in Lagos University Teaching Hospital in 2017 with only one candidate, but thereafter was suspended because of poor subscription. It is still going on in the University of Kenya, where about 20 candidates have completed the training. The second one is the Pediatric Anesthesia Training in Africa, PATA. Nigeria is one of the 3 African countries that is currently running this program. For the Nigerian program, it is currently situated at the National Hospital Abuja, where Dr. Mary Rose Osazua is the site director. Training commenced in 2022 with 2 fellows per year, who are about completing their training, while another 2 have been selected to start in November this year. We also have the Smile Train WACS certificate of completion of training, CCT, in basic and cleft anesthesia. This has just been approved by the West African College of Surgeons, and it is a 6-month training program after the DA, Diploma of Anesthesia, or membership of the WACS. We also have the short courses. The first one is the Safe PEDS course. SAFE means Safer Anesthesia from Education. This is a short CPD CMA course aimed at equipping anesthesia providers with the essential skills and knowledge to deliver safe care to their patients, even in low-resource settings. This commenced in 2019 in Port Harcourt by the Nigerian Society of Anesthetists at the annual national conference. Also held by them in 2020 and 2021. With the Smile Train sponsorship, the NSA had about 169 participants. This year, in conjunction with Smile Train sponsorship, PASoN was able to run 3 courses where 83 participants participated. And the 4th one is scheduled for December in Kano. We also have the PASoN program. This is Pediatric Advanced Life Support course. And 8 courses have been organized and run through NSO ANP. 96 participants were trained. We have the Safe Anesthesia Deliver Smiles. This is a smile train course for physician and non-physician anesthetic providers. It has been run in Nigeria, Gambia, Senegal, and Guinea-Bissau. These local training programs have been very successful in Nigeria and have offered an interim practical solution for the gap in the workforce needed for offering safe anesthesia for our children. Infrastructural development. We have seen some modest improvement in our basic and hospital infrastructure. The road network and mode of transportation is beginning to take shape in the country, especially in our urban centers, where many tertiary centers that offer these services, especially for the very sick ones, are situated. The most recent example is the commencement of the motor rail just commissioned in Lagos a few days ago. There is no doubt that this will help to shorten the delay in presentation to the care facilities. There has also been a significant progress in telecommunications in Nigeria. The number of cellular phone subscription has grown from 3.15 million in 2003 to 195 million in 2021. Thus, this has enhanced communication, or this will enhance communication with the patients, especially the ones for ambulatory daycare surgery. All efforts have been made to improve hospital infrastructure. Some children hospitals are coming up now, and many tertiary centers are now having designated areas for the care of children. Both local and international studies are donating equipment to the children's departments. Examples are Society of Anesthetists in Airway Management with donated video laryngoscopes, Smile Train donated pulse oximeters and fiber optic scopes to Lagos University Teaching Hospital. Kids OR, Kids Operating Room, which is a Scottish charity founded in 2018. They install pediatric operating rooms in low and medium income countries with the aim of bringing safe surgery to every child that needs it. It has donated 2 operating suites each to National Hospital Abuja, Armed Forces Specialist Hospital, Lagos University Teaching Hospital, and National Orthopedic Hospital in Enugu. In 2017, through NSA, 400 live box pulse oximeters were distributed to over 100 hospitals. Now to the contribution of our professional bodies. These have sprung up over the years all over the world, and they play an active role in encouraging documentation, data collation, setting guidelines and protocols to improve standards of teaching and practice. Many high-income countries have these at the national level for pediatric anesthesia. Examples include Association of Pediatric Anesthetists of Great Britain, SPANSA, the National Pediatric Anesthesia Society of New Zealand. And exactly 1 year ago, Nigeria joined by forming its own Pediatric Anesthesia Society of Nigeria, PASoN. It is for which are set up for pediatric anesthetists through training or interest. PASoN has been fulfilling its commitment of improving the standard of perioperative care in children. This it has commenced by the short courses it has been able to organize for both physician and non-physician anesthetic providers within this short period. PASoN now has about 67 registered members, and this webinar is in commemoration of its first anniversary. At this point, I would like to say on behalf of the Board of Trustees, I would like to congratulate the President, Professor Ronke Desalu, and other members of the executive for taking the ball rolling right from its inception. Well done. This is a huge success. The next success we have able to achieve and is the visibility of Nigerian anesthetists on the international global scene. This talk will not be complete without mentioning some Nigerian anesthetists who are now playing major roles at the highest levels in anesthesia. This is a major achievement because it means we can now participate in decision-making at the highest level and play advocacy roles locally in our national development health plans and agenda. We have Dr. Bisola Obembe, who is the current president of the G4 Alliance Governance Council. She was a former WFSA board member and was our former NSA president and is a member of PASoN. Dr. Osazua Mary Rose is a member of the Pediatric Committee of the World Federation Societies of Anesthesia. And Dr. Desalu Ibuyonke is a member of the Publication Committee of WFSA. And forgot to add that she's the major coordinator of SMILE Stream in Nigeria. In conclusion, I would like to conclude that by reminding us about the goal of anesthesia, which is for any age group, is to ensure a comprehensive quality service dedicated to the care of patients and to the education and professional development of the staff. It is obvious that we are still far from achieving this goal in the provision of anesthetic care for our children in Nigeria because of the multiple challenges we face. However, efforts have commenced to find solutions. These must be sustained and improved upon if we are to achieve our goal. The future of pediatric anesthesia in Nigeria is bright. Thank you so much for your attention and for listening. I'd like to make some acknowledgements. The first is Professor Desalu, who provided the bulk of statistics used in this presentation, including some of our published data of some of the surveys carried out by her and collaborators. I'll also thank her for providing the graph of distribution of physician anesthetists, of pediatric anesthetists in Nigeria. I also want to acknowledge the chairman and secretary of the National Postgraduate Medical College Faculty of Anesthesia for providing the data on fellows, and for the president of the Nigerian Society of Anesthesia for data in their directory. Thank you once again for listening. And these are, sorry.
Thank you.
These are the
Thank you. Thank you, Prof, for taking us through the memory lane and reminding us how we have come this far and making valuable suggestions on the way forward. Thank you for the talk on the challenges and successes of pediatric anesthesia in Nigeria. And we appreciate your time and your efforts. Thank you very much. We are grateful. At this point, I'm trying to check if we have any question on Prof's lecture. Yes, somebody was asking a question, but I think we'll try to refer that, talking about how live box pulse oximeters can be assessed, especially for mission and some programs. I think we have to consider that and refer appropriately because of our time. But if there are other specific questions, we need to attend to them as we progress. At this point, we want to move ahead to the fourth lecture, and we'll be talking about pediatric airway management. What's new? You all agree with me, this is a very important aspect of our care in children. And to take us through this, we are privileged to have Dr. Marilyn Stein with us. Dr. Stein grew up in Atlanta, Georgia, and then completed undergraduate and medical degrees at Stanford University. She stayed at Stanford for combined residency training in pediatrics and anesthesiology, and later moved to Boston for a pediatric anesthesiology fellowship at Boston Children's Hospital. She then joined the anesthesia faculty in the main operating room division at Boston Children for a few years before pursuing additional training with the cardiac anesthesia group. She's an assistant professor of anesthesia at Harvard Medical School, and her research interests include difficult airway management in pediatric patients and perioperative management and risk assessment of patients with pulmonary hypertension. Outside the hospital, she enjoys spending time with her husband and two young children and running by Charles River. Glad to have you despite the different time zone. We appreciate your sacrifice. And for the next minute, we'll be glad to listen to you. Dr. Mary Stein, you are welcome.
Thank you so much. It is a great honor and pleasure to be here with you today. Many thanks to Dr. Patrick Olomu for connecting me to you. And thank you to the other speakers for your really fascinating talks so far, and ones I'm very much looking forward to later in the program. As you know, in addition to my clinical work, I'm part of the Pediatric Difficult Intubation Collaborative and focus on improving safety for children with difficult tracheal intubations. Today, I'll discuss some updates on pediatric airway management with a particular focus on making pediatric anesthesia safer. I have no relevant financial disclosures. Images without a reference are from my personal collection and used with the consent of the patients and their families. Our objectives today are to briefly review some key concepts in pediatric respiratory anatomy and physiology, review available data on pediatric difficult airway management, and to discuss practical approaches to pediatric difficult airway management, all with the aim of making pediatric anesthesia safer. And just in case there are other demands on your attention, I like to tell you now what the take-home point will be. When you're faced with a child who requires airway management, please remember the most important thing is to provide oxygen. Providing supplemental oxygen during intubation attempts leads to less hypoxemia. So why do we even need to talk about pediatric airway management? Why does this matter? Respiratory problems are common and account for much of the perioperative morbidity in children. The dreaded situation, the oxygen saturation drops, then the heart rate drops, and you have a child moments away from an arrest. That's what we're trying to avoid if possible and treat if we must. And as you all know, children are different from adults. When we think about neonatal and pediatric airway anatomy, the biggest differences impacting airway management are a relatively large occiput, which makes the shoulder roll useful for aligning the oral, pharyngeal, and laryngeal axes for laryngoscopy, a classically large floppy omega-shaped epiglottis, which often makes a straight blade an easier option for obtaining full laryngeal exposure, and a relatively anterior encephalad location of the glottis, which means that the laryngoscopic view may be more oblique than what is seen in adult patients. In addition to anatomic differences, there are important differences in neonatal and pediatric respiratory physiology when compared with adults. Children have decreased total lung capacity, tidal volume, inspiratory capacity, and lung compliance. They have increased residual volume, closing capacity, respiratory rate, minute ventilation, chest wall compliance, and oxygen consumption when compared with adults. On a per kilogram basis, functional residual capacity and anatomic dead space are fairly constant throughout the lifespan. So what does this all mean? Children have higher oxygen consumption, yet decreased total lung capacity and tidal volume. To make up for this, they increase their respiratory rate to increase minute ventilation. So conditions that decrease respiratory rate and thus minute ventilation, like the induction of anesthesia, can lead to rapid onset of hypercarbia and hypoxemia. Furthermore, even though functional residual capacity is the same on a per kilo basis, closing capacity often exceeds FRC, making infants more prone to airway collapse and atelectasis. Babies will become hypoxemic very quickly. You see here a table and graph of median time to onset of hypoxia in apneic patients. A healthy adult may take 8 to 10 minutes to drop their arterial oxygen saturation, while a school-aged child has less than half that time, and an infant, maybe 90 seconds. Okay, so kids will get hypoxemic quickly, but most of the time you all are intubating children in well under 60 seconds. So while it's certainly something to think about, probably doesn't weigh on your mind for every pediatric intubation. But what about children with difficult airway anatomy, like those pictured here? Microretrognathia, macroglossia, midface hypoplasia, hemifacial microsomia, airway masses and lesions. Studies have shown that difficult intubation occurs in 0.5 to 1% of all pediatric intubations, and that 15 to 20% of those are unanticipated. The numbers get much higher when we're talking about infants. More than 5%, or 1 in 20, have difficult intubations requiring 3 or more attempts. So let's talk a little bit about the Pediatric Difficult Intubation Registry. Because of the problems of difficult airway anatomy and difficult intubations, the registry was formed in order to study this problem and hopefully come up with solutions to help keep patients safer. The registry enrolls children younger than 18 years of age with difficult direct laryngoscopy who undergo elective and non-elective tracheal intubation supervised or performed by an anesthesiologist in any hospital location. So often operating rooms, emergency departments, and intensive care units. Children can be entered into the registry due to meeting one of 4 criteria. Difficult direct laryngoscopy, defined as either a grade 3 or 4 view, so only epiglottis or no identifiable laryngeal structures with direct laryngoscopy. Limited mouth opening such that direct laryngoscopy cannot be performed. A patient who's failed direct laryngoscopy within the past 6 months, or a patient in whom an alternative airway management technique was selected because of concern for harm or low chance of success with direct laryngoscopy. The site PI at each PD registry center identifies cases that meet the registry inclusion criteria, and then a data collection form is completed as close to the time of clinical care as possible. The data collected includes demographics, ASA physical status, elective or emergency case, presence of a syndrome associated with airway anomalies, physical exam findings, such as limited mouth opening, microretrognathia, short thyromental distance, presence of masses or limitations in cervical range of motion, just to name a few. The data also includes anesthesia induction method, ease and success of mask ventilation, use of airway adjuvants and supplemental oxygen, and outcomes, including intubation success and complication. We also collect clinician data, including level of the primary clinician managing the airway and fellowship training and years of experience post-fellowship of the responsible attending. Our complications list was modified from the pre-existing National Emergency Airway Registry for Children and are categorized as non-severe or severe. The registry started with 13 academic children's hospitals in the United States. Each participating institution obtains IRB approval from their local IRB, and we've now grown to 61 centers with 44 that have submitted data on more than 8,000 patient encounters. The Children's Hospital of Philadelphia hosts a secure web-based data entry portal, and each center site PI develops plans for faculty education, site-specific compliance, and audits for data completeness and missed cases. There's also extensive data quality efforts spearheaded by the team at CHOP. All right, so that's a lot of kids with difficult direct laryngoscopy being cared for in a lot of centers around the world. So what have we learned? The first study from the PD registry was designed to look at the success rates of various tracheal intubation techniques, define the type and incidence of complications associated with difficult airway management in children, and identify factors associated with complications. Data on 1,018 patients was collected from 13 centers between August 6, 2012 and January 31st, 2015. Direct laryngoscopy was used for the first attempt in 46% of cases, but was the successful device in only 12% of cases. A fiber optic bronchoscope or flexible scope was used as the first attempt device in 28% of cases and was the successful device in 37% of cases. And a glide scope or hyperangulated video laryngoscope was used as the first attempt device in 18% of cases and was the successful device in nearly double that, 34% of cases. Complications were common, with at least one complication occurring in 20% of cases in the registry. Hypoxemia occurred in 9% of cases, and cardiac arrest occurred in 2% of cases in the registry. All cardiac arrests were preceded by hypoxia. Supplemental oxygen during intubation attempts was only provided in 10% of cases. Analysis showed that patient weight less than 10 kilos and those with short thyromental distance noted on physical examination experienced an increased incidence of complications. More than 2 attempts at tracheal intubation and persistence with direct laryngoscopy, defined as 3 or more attempts with direct laryngoscopy prior to switching to an advanced technique, were also associated with increased incidence of complications. Or, as these graphics nicely demonstrate, smaller babies had more problems, and more attempts, more problems. Okay, I'm guessing this makes sense to many of you based on your own clinical experience. But what do we do with this information? Since the original publication, there have been 8 additional research publications from the PD registry, including 1 multi-center randomized controlled trial. I'm going to take some time to briefly highlight my main learning points from a few of these studies and what they've added to my practice. First up, we have an examination of success and complications for glide scope video laryngoscopy compared to direct laryngoscopy. This study includes cases from 20 centers from August 2012 through April of 2017. You can see in the pictures on the top right, the glide scope has an angulated blade with a video system at the tip that is then projected onto a screen. This blade is designed to allow clinicians to look around the corner and see on the screen what they cannot see directly with their eyes. I find it particularly useful for patients with very anterior airways and those with limited mouth opening. In this study, there were 877 patients who underwent intubation attempts with the glide scope and 828 patients who underwent intubation attempts with direct laryngoscopy. First attempt success and eventual success were much higher with the glide scope than with direct laryngoscopy. 53% first attempt success compared to just 4% with direct laryngoscopy, and 82% eventual success compared to 21% with direct laryngoscopy. This finding was true even in those patients weighing less than 10 kilos, although the overall success rates with the glide scope were lower in this group. Remember that as we'll be coming back to this finding in the next study. This study redemonstrated the significant association of number of attempts with occurrence of complications, with each additional attempt associated with a twofold increase in the incidence of complications. My most important takeaway from this study is that direct laryngoscopy is very unlikely to be successful in children with difficult airways. And since the incidence of complications increases with each additional attempt, it is imperative to select the technique we think is most likely to succeed. And if that doesn't work, transition to an alternative technique early. This next study is the intellectual follow-up to the glide scope versus DL study. Here, we're looking at hyperangulated blade video laryngoscopy compared with standard Miller and McIntosh blade video laryngoscopy. The big difference between the blade types is the hyperangulated blades are designed so that the video sees around the corner what the laryngoscopist cannot see with his or her own eye. The standard blade video laryngoscopes can be used to perform direct laryngoscopy or video-assisted direct laryngoscopy, where one clinician looks directly in the patient's airway, while a second collaborator or supervisor watches on the video screen, giving everyone a shared view. This study includes patients from 28 institutions from March 2017 to January 2020. Importantly, in March 2017, there was an update to the data collection form to allow more granular information on each attempt. There were 740 patients in the hyperangulated blade group and 529 in the standard blade group. There was no difference in first or eventual success rates or complications in the overall groups. However, when evaluating the subset of patients weighing less than 5 kilos, both first and eventual success rates were significantly higher with standard blade video laryngoscopy. 51% versus 26% initial success rates, and 81% with standard blade video laryngoscopy compared with 58% with the hyperangulated blades. Multivariable analysis revealed that standard blade video laryngoscopes had 3 times the odds of first attempt success compared with hyperangulated blades in these infants and neonates weighing less than 5 kilos. This study also redemonstrated the significant association of number of attempts with occurrence of complications, with more than 2 attempts associated with a more than 5x increase in the odds of a complication. For me, the compelling message of this study is that standard blade laryngoscopy is probably my best first choice for neonates and small infants. In my own practice, I find that while I can often get a good view with a hyperangulated blade, the challenge comes in manipulating the endotracheal tube to the glottis. In a small infant, there's limited space for manipulation, and it's often more straightforward to line up the endotracheal tube with a standard blade. I reserve the hyperangulated blades for infants with severe microretronathia in whom I don't think I'll be able to get a view with a standard blade, and for larger children and adolescents. The next study that I'll discuss is the video laryngoscopy in small infants, or VISI trial. While the other studies were all based on registry data, VISI is a prospective randomized controlled trial excuse me, designed by members of the PD registry to evaluate whether standard blade video laryngoscopy provides higher first attempt success rates than direct laryngoscopy in infants. The study block randomized 564 infants with anticipated normal airway anatomy undergoing an anesthetic with planned tracheal intubation at 5 pediatric centers between June of 2018 and August of 2019, stratified by site and clinician training level. The infants were randomly assigned to either direct laryngoscopy or standard blade video laryngoscopy, and guardians were blinded to the assignment. We found that standard blade video laryngoscopy resulted in improved first attempt success rates, 93% versus 88% with direct laryngoscopy, and decreased incidence of severe complications, 2% with the video laryngoscope versus 5% with direct laryngoscopy. These results were particularly striking for infants weighing less than 6.5 kilos, 92% first attempt success rate with the video scope versus 81% with direct laryngoscopy. This study has dramatically changed my practice. Where DL was previously my go-to approach, I now use video laryngoscopy routinely for neonates and infants, both for my trainees and for myself. When I'm the person managing the airway, I will use the video laryngoscope blade to obtain a direct view of the glottis, and then we'll confirm the endotracheal tube passing on the video screen. I'll maintain a video view of the tube passing through the glottis until the stylet is removed if we used one, and we've hooked up the ventilator and confirmed ventilation. We call this video-assisted direct laryngoscopy. So not exactly what the VISI trial was evaluating, but I think it brings together the benefits of both techniques and is fantastic for educational purposes. Next, I'm going to discuss 2 large observational cohort studies from Europe. These are not from the PD registry, but I think they are incredibly important in understanding the current issues in pediatric airway management. The remarkable APRICOT study was a prospective observational cohort study of more than 30,000 children less than 15 years of age undergoing anesthesia care and airway management at more than 200 centers in Europe between April 2014 and January 2015. Before we even get into what they found, I want to take a moment to appreciate the incredible work and collaborative effort this study represents. The incidence of difficult intubation was 0.9%. More than 13,000 children underwent tracheal intubation with direct laryngoscopy used successfully in more than 98% of cases. In those rare cases where an alternative method was used, video laryngoscopy was used in 1.3% of cases and flexible intubation in 37 total cases, or 0.3%. The incidence of a critical respiratory event, that is bronchospasm or laryngospasm, was about 1.2%, and the risk of a critical respiratory event increased 2-fold with more than 2 attempts were made to secure the airway. The subsequent Nectarine study was a prospective observational cohort study that included more than 5,000 infants up to 60 weeks postmenstrual age undergoing anesthetics from March 2016 to January 2017 in 165 centers in 31 European countries. This study was designed to look at intraoperative and postoperative critical events and assess morbidity and mortality. It also provided an opportunity to describe and evaluate airway management practices in these infants. They found a 5.8% incidence of difficult intubation in this population of neonates and infants. Strikingly, severe hypoxemia occurred in 40% of cases of difficult intubation and was accompanied by bradycardia in 8%. Now, 20% of these patients classified as difficult to intubate had a grade 1 view on direct laryngoscopy, and another 30% a grade 2 view. This led the authors to propose that rapid onset of hypoxemia may have contributed to multiple attempts in many cases more than anatomic difficulty. So are there any interventions that we can make to improve safety? The first thing to think of is supplemental oxygen. This table is from an old study from 1959, one that we would certainly struggle to get ethics approval for now. 8 healthy adult volunteers were intubated and paralyzed and provided apneic oxygenation without ventilation. All 8 maintained arterial oxygen saturation for the duration of the study. They had to stop the study due to profound hypercarbia and acidosis, but not hypoxia. And multiple studies have shown both high flow and low flow oxygen can extend the time to the onset of hypoxia, or the safe apnea time in children as well. This has the obvious benefit of avoiding or at least delaying hypoxia and the even more ominous associated bradycardia. But it has another benefit as well. Prolonging the safe apneic period likely gives us more time to successfully troubleshoot and intubate on a given attempt. All this to say, oxygen is our friend. There are a variety of techniques to provide passive oxygenation during airway management, including simple nasal cannula, high flow nasal cannula, modifications of nasopharyngeal airways, supraglottic airways, and endotracheal tubes, as well as channels on some laryngoscopes designed to allow oxygen flow. I think the best technique is the one that you'll use, but I do encourage you to find a technique and use it. Here, you see a simple low flow nasal cannula being used to provide supplemental oxygen for a dysmorphic premature neonate. This is simple, doesn't require special equipment or training, and has been shown to significantly prolong the safe apnea time and reduce the incidence of hypoxemia in children. And this brings us to another study I want to discuss, also not from the PD registry, but still very valuable. Thomas Riva and colleagues in the Optimize Collaborative performed a multi-center randomized controlled trial of direct laryngoscopy versus standard blade video laryngoscopy in neonates and infants, very similar in design to VISI, but with one key difference. In both groups, the babies received 1 liter per kilo per minute of supplemental oxygen during laryngoscopy. We see that again, there was a higher first attempt success rate for video laryngoscopy compared with direct laryngoscopy, 89% versus 79%. But what I think is really interesting is that there's no difference in the incidence of complications and a very low rate of hypoxemia overall. So yes, video laryngoscopy improves first attempt success rate. But I think the really important lesson here is that providing supplemental oxygen leads to less hypoxemia. All right, so let's try to put this all together with a case. We have a 14-year-old child with Menkes syndrome presenting with hypercarbic respiratory failure in the ICU after extubation following a tonsillectomy. He's profoundly developmentally delayed, has severe obstructive sleep apnea, and on exam is obtunded, obstructing, combative, and has retrognathia and protruding teeth. A jaw thrust and application of CPAP improve, but don't completely resolve the obstruction, and the ICU has called you to assist with reintubating him. They're concerned because previously he was a difficult mask and required placement of an LMA to oxygenate and ventilate after induction. ORL performed laryngoscopy and had a grade 4 view with a PASoN scope in the operating room, and he was intubated with a rigid bronchoscope with note made of an extremely anterior airway. Okay, so what are we going to do? It's too late to call in sick. We've done a focused history and physical, which is as we discussed. What's going to be challenging? He's the real deal, difficult mask, difficult laryngoscopy. So we have to determine how will we oxygenate? What's our plan A? And what are our backup plans? Who else do we have around and who do we want to have around? Fortunately, we know that he's been able to be ventilated with an LMA. So let's walk through the new ASA difficult airway algorithm for pediatrics together. Do we think that this patient will have difficult laryngoscopy? Yes. Do we think he will have a difficult mask ventilation? Yes. So the first decision point is, can we do this awake or sedated? The pediatric algorithm acknowledges that awake intubation may not be possible in most pediatric patients and has an awake/sedated arm of the algorithm in place of the awake arm in the adult algorithm. A recent analysis from the PD registry propensity score matched 58 patients who received sedation for tracheal intubation with 522 who received general anesthesia. The groups did not differ with respect to success rates or complications. However, more than 25% of cases in the sedation group converted to GA for successful intubation. For me, this pushes me more towards a general anesthetic in many cases. And now for our patient, we know that an SGA or an LMA was successful earlier, and that given his developmental delay and inability to cooperate with an awake or sedated intubation, we will pursue intubation after induction of general anesthesia. So for this patient, we choose intubation after induction of general anesthesia. We optimize positioning and find that we're able to effectively mask ventilate the patient. Then we apply nasal cannula to allow passive oxygenation during our laryngoscopy with a hyperangulated blade video laryngoscope. The laryngoscopist obtains an excellent view, but is unable to bring the endotracheal tube to and through the glottic opening. What now? This is where a hybrid technique incorporating both video laryngoscopy and a flexible scope may be particularly useful. Here, we can use the flexible scope as a steerable stylet to bring the endotracheal tube to and through the glottic opening. You see the video laryngoscope view on the left and the flexible scope view on the right, and together, we're able to safely intubate the trachea. And we performed a recent analysis comparing 140 patients using this hybrid technique, matched for age, weight, ASA physical status, PD registry entry criteria, abnormality on airway exam, identified syndrome, and anticipated difficulty, to 560 patients using flexible intubation alone in the pediatric registry. The hybrid technique had a 70% first attempt success rate and a 90% eventual success rate, and complication rate of 15%, similar to flexible intubation alone, despite being more likely to be used as a rescue technique that is used after other techniques have failed. The hybrid technique had increased success rates in larger patients, making it an especially useful technique for older children and adolescents. Okay, we've successfully cared for our patient, and in the process, we've had the chance to review some key concepts in pediatric respiratory anatomy and physiology, review available data on pediatric difficult airway management, and discuss practical approaches to pediatric difficult airway management. Hopefully, I've been able to give you some new ideas to apply to your practice to help make pediatric anesthesia safer. We've highlighted the importance of oxygenation, planning ahead, limiting attempts, and using an SGA for rescue. And if there's only one thing you remember from today, I hope it's this. When you're faced with a child who requires airway management, please remember the most important thing we can do is provide oxygen. Thank you so much for inviting me here today. It's been a great pleasure to get to join you and discuss pediatric airway management. I've included my email address here. Please feel free to contact me with any questions or if you'd like to discuss further. I'm also happy to provide copies of any of my references. Thank you.
Thank you so much, Dr. Stein, for taking us through this section. And we so much appreciate the practical approach to the discussion. We have your contact if there are questions. We wanted to attend to them. But presently I checked, there is nothing for now, but as they come up, we will want to address. Before we move to the next and the last lecture tonight, we want to take two of our goodwill messages. We have video sent in by Smile Train and by the Critical Care Society of Nigeria. Please, let's have this. So I can see the voice has not been activated. It's all right, please, let's take this down as we move on to the next and the last lecture tonight, evaluating the potential benefits and harms in clinical research involving pediatric patients. To take that lecture is our own Dr. Layinka Eyelade. She's a consultant anesthetist, a teacher, a researcher with special interest and passion for pediatric anesthesia. She's from the College of Medicine, University of Ibadan, and also the Center for Bioethics Research, Ibadan, Nigeria. We are glad to have you tonight. You are welcome, ma'am.
Good evening, my teachers in the house, senior colleagues. I thank the National President of the Pediatric Association of Nigeria and the Board of Trustees for asking me to give this topic and to be part of this webinar. I'll be talking on the evaluating the potential benefits and harms in clinical pediatric anesthesia research. I hope you can hear me.
We can hear you, ma.
Thank you. I want to start by giving us the definition of research as contained in our own Nigerian National Code of Health Research Ethics, which is available at the address shown. Research here is defined as systematic investigation, including research development, testing, and evaluation, designed to develop or contribute to generalizable knowledge. So when we are doing research, this has to be in our mind all the time. What are you contributing to knowledge? Are you bridging knowledge gap? Are you adding to existing knowledge? Is it about devices, strategies, or techniques? So research, particularly in children, has to be of social and scientific value, not just testing something that is not of benefit to children. In research ethics, children are seen as a vulnerable population because they lack the capacity to provide informed consent, and they are at risk of incurring harm, of exploitation, of coercion. So special protection is required to avoid exposure to unjustifiable risk, harms, and exploitation. If we look at the population of Nigeria, which has been alluded to by the national president in our opening remark, as well as by our own referred Professor Ushimo, when she was delivering a lecture on challenges and successes of pediatric anesthesia in Nigeria. 43% of our population are children. This is a very high burden of disease. And in Nigeria, these children are also prone to very high mortality, as we see in our under 5 mortality rates. So actually providing anesthesia for this group in our population is a challenge that we must all rise up to. Now, in anesthesia, what are the type of research that we do? I have grouped them under these 4 headings, which are pragmatic clinical trials, the primary purpose of which to inform decision makers regarding the comparative balance of benefits, burdens, and risk of biomedical or behavioral health interventions. So when we are doing clinical trials on new drugs, new technique, new strategy, this could be pragmatic clinical trials. But as a researcher and an examiner, and having supervised so many dissertations, the majority of the research that we do in Nigeria fall under the second heading, which is comparative effectiveness researches, where we are comparing the benefits and risk of different existing interventions and strategies to prevent, to diagnose, treat, and monitor patients under anesthesia. We could also do research with biospecimen, like specific tissues, blood samples, serum, plasma sample, saliva or sputum, particularly in this era of genomic studies and other bodily fluids. Now, we have also participated in many global health researches, which are multi-site, international, and collaborative researches. The scope of clinical anesthesia in the pediatric patients. I want to look at it from preoperative, intraoperative, and postoperative scenarios. In the preoperative scenario, we're looking at counseling. We have different age categories for our pediatric population. We have the preterm, we have the neonates, the small infants, the toddlers, the school-age children, the adolescents. How do you counsel these ones and prepare them for anesthesia, and surgery. So this has been an area where a lot of study has been done. We've also looked at minimal fasting regimen, because in this part of the world particularly, we have seen that sometimes children are fasted for over 8 hours while waiting for their turn for various reasons, depending on the institution where you are. So looking at fasting regimen in particular institution and in general population has been a topic of research in this part of the world. Now, recently we have been looking at non-pharmacological pre-medications. We are all aware as an ACPs of pharmacological methods that you can use to pre-med our patients. And of course, the new entrance into the pre-med armamentarium is remimazolam. We know of midazolam, but this is remimazolam, which is also an ultra short-acting benzodiazepine, which is being tried in the developed country as a pre-medicant. Now, when we look at intraoperative scenarios, airway management, and the last speaker really dwelled a lot about airway management and what we can do, to make airway instrumentation safe for the pediatric patients. The new thing I have learned is that while apart from pre-oxygenation, there's also something called para-oxygenation, which is apneic oxygenation. So even when you are giving muscle relaxant to your patients, you can also give oxygen. And a lot of research has been done in this area. Now we talk of medications and technique. An example that readily comes to mind is the macro to micro propofol emulsion, which is being tried now to reduce pain on injection for propofol. We also have infusion models, total intravenous anesthesia or target control infusions for children. These are areas of researches. When we talk of monitoring and equipment, various equipment are coming on board, for our use for monitoring during pediatric anesthesia. An example is the bispectral index, which we use to monitor depth of anesthesia, particularly when we are giving out sedation, conscious sedation for procedures in this group of patients. Use of regional anesthesia is becoming increasingly important. And I think our first speaker, gave a good lecture on which regional anesthesia for neonates. So we are talking of point of care ultrasound scan, which has really improved the affordability of peripheral nerve blocks for children. We talk of the new local anesthetic agent, Articaine, 4%, which can be used even for day case surgery. In the postoperative setting, enhanced recovery has been the major area of study. And one area I have participated is in reducing the incidence of emergence agitation in pediatric age group, particularly when they have just undergone eye surgery and both eyes are closed. They're so agitated, and we'll be able to find something that we can use to reduce this emergence agitation. A lot of studies going on in this area. Now, one other area that is current is effect of anesthesia medications on neurodevelopment. An example is the Mayo Anesthesia Safety Kit, MASK, and the Pediatric Anesthesia Neurodevelopment Assessment, PANDA. Both of these studies have found out that single exposure to anesthesia does not contribute to cognitive impairment or neurodevelopment abnormality in children, particularly infants and neonates. However, multiple exposure has been found to impair neurodevelopment in this group of patients. But what has not been found definitely is it the duration of the anesthesia or the number of exposure to anesthesia? This is an ongoing area of research in pediatric anesthesia. Now, when we talk of critical care, we talk of resuscitation protocols. And I'm happy that the Pediatric Anesthesia Society of Nigeria is engaged in training in the subspecialty of pediatric anesthesia. So we're learning pediatric basic life support and pediatric advanced life support, which is very important. One of the lectures that we have had today is what if something goes wrong? All practicing pediatric anesthetists must be able to give effective cardiopulmonary resuscitation. Now, what are the potential benefits that we can derive by engaging children and adolescents in research? Because today we talk of inclusiveness, and children and adolescents are to be part of research because they have their own physiological needs, they are still growing, and sometimes you cannot extrapolate the findings in adults to this group of population. So we are looking at improved anesthesia and surgical outcomes. We're looking at reduction in perioperative morbidity and mortality. And as earlier alluded to, airway complication is so common that, you know, we've got to find a way to reduce this. We're talking of better pain control, including postoperative analgesia, knowledge of effective dosing of medications, including the frequency, the intervals, and the effects on neurodevelopment and other cognitive attributes. This becomes important when we're talking of pediatric anesthesia for the preterm child and the neonates and the small infants, because their organs are still developing. They're not mature enough to handle the drug dosages. And here we are also talking about pharmacodynamics and pharmacokinetics of the medications that we give during anesthesia. Now, it may be bridging knowledge gaps or improving existing knowledge on pediatric anesthesia care. Others include improved technique of anesthesia and monitoring during anesthesia. Those are potential benefits. Now, I've included these pictures and it's talking about standard of care. When we're talking of research in pediatric anesthesia, we need to establish what is going to be our own standard of care in Nigeria. Now, some of the research that I have, partaken, that I've initiated includes this pediatric sedation. This is a child undergoing orthopedic procedure. Now, the standard of care is that oxygen must be available, anything can happen, and the anesthetist must be able to rescue the child. Now, one of the observation in the recently concluded African Surgical Outcome Study 2 was that failure to rescue was one of the complications that is so common with non-physician sedation, whether in adults or in the pediatric age group. So monitoring, ready and getting ready all that it will be necessary in case of cardiac arrest, hypoxia is a standard of care where you're talking of pediatric sedation. Now, when we're talking of monitoring, we have also, monitored depth of anesthesia using bispectral index in some of these patients. And the outcome has been published, and we were using TIVA, because when you use total intravenous anesthesia, you actually want to know that your patient is asleep when they are supposed to be asleep, and the level of sedation or the level of unconsciousness. Also in cleft lip and palate surgery, using appropriate equipment, appropriate airway devices. When we first started the cleft smile train, we were provided with everything that we needed, including the RISE tube. So you don't look for anything. Everything that you needed is available. I'm not sure that is the case now in many institutions, including when you need a reinforced tube, because we know that many of the devices, the instruments, airway devices that we use in children are so scarce in this part of the world, because how many hospitals are actually participating and doing pediatric surgery? Very few. So most of these equipments, airway devices that we use are often kind of instruments. And we know in Nigeria, our administrator will tell us that we have to procure 3 quotations for laryngoscope or fiber optic, whatever you need. Where are you going to get 3 quotations from? So we need to establish a standard of care for our practice in this part of the world. And for global practice, there is this article that was published in the Canadian Journal of Anaesthesia in 2018, and titled World Health Organization and World Federation of Society of Anesthesiologists International Standard for a Safe Practice of Anesthesia. In this paper, every facility equipment that is needed according to your institution, including primary level institution, secondary level health facilities, and tertiary health care facility, are all listed in this article, which we can read in our leisure. Now, what are the ethical requirements when we're doing research in children? One, it has to have social and scientific value. It cannot just, it cannot be a play. I just want to find out. There must be cogent reason for us to be doing research in children, because adults are there. Couldn't adults be used? So unless there is unless it's absolutely necessary, children and adolescents should not be involved. But talking of inclusiveness, we can do research that are of needs, of health needs to that population. The second is favorable risk-benefits ratio. In short, the benefits derivable from that research must be more than the risk associated. Now, our research protocol has to be reviewed by the Health Research Ethics Committee, and we have to maintain the patient-physician relationship, which is based on trust. And the society also trusts us as medical doctors not to use their children as guinea pigs. So there must be equitable selection of participants, and informed consent must be obtained from the parents, the guardian, or any other legally authorized representative, including assent from the child. Data monitoring for safety, adequate provision to ensure privacy and confidentiality, and special protection for children. Now, the potential harms. Many of these potential harms could be physical, like inadvertent overdose of medications, and that's one of the reasons why we would need to do research in children and adolescents. It could be pain from venipuncture and lumbar puncture, particularly when you're doing central neurasal blockage. And in fact, lumbar puncture or central neurasal blockage constitute more than minimal risk, because the child is then is at risk of many neurological complications. We also talk of cognitive impairments, which is still being studied. It could be emotional harm. We talk of communication barrier, particularly in pre-verbal children who are not able to communicate, and you're looking at subjective symptoms like acute pain. How are you going to relate with that child? So most times we will rely on their caregiver, so definitely we cannot rule out observers' bias when we are eliciting these subjective symptoms from these children. We also need to protect their privacy and confidentiality, particularly the older child and the adolescents. And we should not expose them to more than minimal risk. For example, exposure to radiation, injection into spinal or epidural space. Those are more than minimal risk. Now, getting consent or assent from the older child. I put in here a publication from the Punch newspaper on 13 September 2022, claiming 14 million Nigerian children are deprived of education, particularly in the rural area. So how do we get assent? How do we get consent from these children? What language are we going to use? This is one area where we have to be innovative in how we obtain assent from these children. How do you communicate the research procedures to them so that they can agree. Whatever the case, a child refusal to participate in research is taken as refusal, particularly the older children, even when their parent has agreed. If the child says no, it is no. For informed consent, which we're going to take from the parents or the guardian, you will know that the pediatric patient will come to the hospital with their parents. And that's why I've included a picture here where we went on an outreach and, they are always with somebody. And the principles of respect for person, which is autonomy, demand that informed consent be obtained from parent, guardian, or legal representative. There are different consent models that we may use. One is the integrated consent model, because like I said earlier, most of our studies are comparing effectiveness of existing interventions. So it's part of the routine care that patient will receive. So the consent for the research is taken together with the consent for the routine care. Another model is the broadcast notification. Many of us who participated in the ASOS, African Surgical Outcome Studies Trial 2, know that we were given the posters to place in prominent location within the health facility, telling people, our potential participants, that there's an ongoing research in this area of the hospital. And I have seen that broadcast for other genomic research within my own hospital. So you have the broadcast notification that makes people be aware that research is going on here. Because if they don't know, it's also a point for medical legal issues. Now, the third option is the modified opt-out. The modified opt-out model is that, particularly when we participate in observational global health researches, where we're just observing an intervention or a behavior, now we're recruiting all patients that comes to the facility are going to be recruited. So it's a modified opt-out. Unless the patient, we are not going to inform the patient that their data will be used in the research and they are free to opt out. So we assume opt-in for every patient that comes to the facility during the period of the study. Now, the researcher could also be a source of harm. And so there are criteria for a researcher, the qualifications and years of direct experience in conducting research at the proposed sites. This is very necessary. Speaking and understanding the local language and familiarity with the local culture is very important. So in Pediatric Anaesthesia Society of Nigeria, when we began to collaborate in international researches, this is one issue we have to look at. Our researcher has to understand the local context in which the study is being carried out. Now, local certification in conducting human research is also necessary. In my own institution, when you are submitting your research proposal, you will also submit a certificate from CITI ethic courses. There are other internet courses like the Amanet course on ethics to show that you have undergone some training in how to conduct research in human subjects. The clinical or the research workload of the would-be researcher is also important. How much work are they doing in this particular site? Can they be part of this global health research? Now, for all researchers participating in a particular study, we have to declare our financial and other conflicts of interest. And like I said earlier, training in research ethics, particularly now that we're doing subspecialty training in pediatric anesthesia, should include human subject protection. Now, what are my recommendations for our society? we need to create anesthesia database, probably at every institution, to gather data and information on our pediatric surgical cases workload, reporting of adverse events, complications, and satisfaction with overall patient care. The current training that is ongoing by the Pediatric Anesthesia Society for subspecialty has to become structured so that as part of the certification, we can have the resident also do a research. Will be an incident study, will be case scenarios, will be observational studies. We need to start somewhere. And we need to encourage and reward our members who are actively engaged in research activities. I don't know how many minutes I have left, but I want to conclude here because I was told I have just 20 minutes. Research in children is not an easy task, particularly when you are dealing with pre-verbal children who cannot communicate, and you are depending on the carers and the healthcare professional to provide information and data. So our research protocols should be clear enough to ensure safety for these children and adolescents, to ensure autonomy, which is respect for person, to ensure confidentiality and well-being of the participating children. Full parental consent and the child's assent according to their age is very important. Institutional and National Health Research Ethics Committee will need to provide an independent review of the research protocol. These are some of the references. I thank you all for your attention. I congratulate all members of the Pediatric Anesthesia Society of Nigeria on the occasion of our 4th year anniversary. Thank you all.
Thank you very much, Ma, for your presentation and for highlighting and opening our eyes to different areas, talking about the benefit and harms in clinical research involving pediatric patients. As questions come up, we will be glad if you can take them. But for now, I can't find anything on the chat. So while we are waiting, let's quickly take goodwill messages. Sorry, we can't hear that. I'm not sure any other person can hear you. So please, we want to appreciate Smile Train and the Critical Care Society of Nigeria. We received your videos. Unfortunately, due to some technical challenges tonight, we may not be able to play them. But we have 2 other messages from PASoN, Association of Pediatric Surgeons of Nigeria, and the Society of Specialists in Airway Management. To read that to us, I want to welcome Dr. Efosa Edobo. Let's take those 2 messages from.
Yeah, good evening. Thank you, Dr. Arion. Good evening, Madam President. Good evening, erudite faculty and resource persons. Good evening, dear participants. My job this evening is to read out the goodwill message from our sister association, the Association of Pediatric Surgeons of Nigeria, PASoN. Felicitations, felicitations, felicitations. On behalf of the National Executive Council and distinguished members of the Association of Pediatric Surgeons of Nigeria, PASoN, we wish to heartily and profoundly felicitate with the President, executives, and members of the Pediatric Anesthesia Society of Nigeria, PASoN, on this auspicious occasion of your 1-year anniversary and annual general meeting. PASoN had longed for the birthing of your association, and we received with great joy the good news of the pleasant reality a year ago. In this past 1 year, we have observed massive interest in the unique specialty of pediatric anesthesia amongst your members. PASoN also views your growth and development as theirs, and that of the overall child health in Nigeria, because our success is in most of the things we do depends on our deep collaborations with the pediatric anesthetists. Having seen off a full year successfully with a lot of impacts, we look forward to your greater years of impacts and deeper collaborations. Congratulations once again, and warmest wishes of fruitful deliberations and impactful scientific conference. Yours sincerely, Professor Roland I. Oswoji, President, Dr. Jide Ofo O. Ugu, Secretary General. Thank you very much, PASoN, for this wonderful goodwill message. I will now read the goodwill message from the Society of Specialists in Airway Management, SSAM. Congratulatory message on the first anniversary of the Paediatric Anesthesia Society of Nigeria, PASoN. On behalf of the National Executive Committee, Board of Trustees, and members of Society of Specialists in Airway Management, I congratulate you on the occasion of the first anniversary of the Society. The establishment of PASoN has created a community of practice for anesthetists committed to the care of pediatric patients. We have observed with keen interest how the Society has engaged its members and sister societies in activities towards the improvement of the practice of pediatric
Dr. Adobo, we
anesthesia.
can't hear you. Can anybody hear him, please?
Hello.
Dr. Adobo can hear him.
Okay, thank you very much. The establishment of PASoN has created a community of practice for anesthetists committed to the care of pediatric patients. We have observed with keen interest how the Society has engaged its members and sister societies in activities towards the improvement of the practice of pediatric anesthesia in the country. We are grateful for your support and contributions in the training and research in pediatric airway management. We look forward to more collaborations with PASoN. We hope you have engaging deliberations, and we wish you a successful conference. Congratulations again. Yours sincerely, Dr. Aderonke Adesanya, President, SSAM Nigeria, Dr. Ibrahim Salim Abdullahi, Secretary, SSAM Nigeria. Thank you very much, Society of Specialists in Airway Management, for this beautiful goodwill message on the occasion of our first year anniversary. Thank you very much. Dr. Aaron.
Okay, thank you, Dr. Adobo, for delivering those messages. We want to appreciate everyone for being patient and for staying all through this session. We'll be rounding up in a short while. One of the presenters, especially the lecture on pediatric airway management, was new. We have some materials which I've uploaded on the chats. We can download those materials if necessary. I mean, if you will be needing them. Also, some issues raised or questions have been taken note of. Some of them have been answered already. So if there are other things, we'll see how we can do that. Talking about the slides some people were requesting for, I know we'll be having the recording, but about the slides, we consider what you can do about it, so that anything that is useful for us from this webinar, we can make them available through appropriate forum. At this point, I want to welcome Dr. Mary Rose Osazua, the Vice President PASoN, to give the the vote of thanks.
Good afternoon / good evening, everyone. On behalf of the Pediatric Anesthesia Society of Nigeria, I would like to thank you all for attending and participating in this anniversary webinar. Our special thanks go to our speakers, Dr. Raymond Ndikonta, Dr. Rebecca Gray, Dr. Marilyn Stein, Professor Olushola Kushimo, and Dr. Olainka Eyelade. We thank you for taking your time to give us brilliant lectures. And I'm very sure all of us here have learned so much from your lectures. We also want to thank the organizations that have sent in congratulatory messages. We thank the Nigerian Society of Anesthetists, our parent body. We thank the SMILE Train. We thank the Pediatric Anesthesia Training in Africa. We thank the Society of Obstetric Anesthetists of Nigeria, the Association of Pediatric Surgeons of Nigeria, the Society of Specialists in Airway Management, and International Critical Care Society, Nigeria. Thank you so much for your congratulatory messages and warm felicitations. Thank you to all our participants. This could not have been possible without your registration and attendance. We look forward to even greater things for the Pediatric Anesthesia Society of Nigeria, so stay tuned. We're going to be involving you in so many things for the greater good of our children. Thank you for attending once more, and God bless you. Have a good evening and the rest of the day.
Thank you, Dr. Sazo. Thank you, everybody.
On this note, we want to draw the curtain for this first anniversary celebration of Pediatric Anesthesia Society of Nigeria. Good evening.
Thank you, Mayowa. I don't have your contact, but thank you. Thank you. Everything worked out well.